Sometimes we're not ourselves. There's no one I can turn to. And I know all the feelings that we shared are in the past. And I know your relationships are never meant to last. And I'll take some time, but I'll be alright. We're moving on. We're moving on. I know times are
of Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah, Deputy Director General of Health for Research and Technical Support, Ministry of Health, Malaysia. Please rise. National Anthem. Please be seated. Assalamualaikum warahmatullahi wabarakatuh. Good morning and salam Malaysia Madani. Yang berbahagia, Datuk Dr. Nur Fariza binti Ngah, Deputy Director General of Health for Research and Technical Support, Ministry of Health, Malaysia. Yang berusaha, Dr. Murizal bin Zainul, Manager of the National Institutes of Health, NIH. Yang berusaha, Dr. Haji Tahir bin Aris, Chairperson of the 24th NIH Scientific Conference 2023. Distinguished guests, ladies and gentlemen, welcome to the 24th NIH Scientific Conference 2023. To begin our program, we would like to invite Encik Muhammad Zulhilmi bin Kamaruddin to lead the Doa recitation. Please welcome.
الفاتحة بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين آمين بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين وعلى آله وصحبه أجمعين. Praise be to Allah, the Lord of the worlds. Peace and blessing be upon our Prophet Muhammad and his companion, and for those who follow his example until the end, the judgment day. Allahumma ya Allah, on this blessed morning, in conjunction with the 24th NIH Scientific Conference, we seek your blessing for a flawless progress of this event from the beginning till the end. We seek your guidance to stay clear of events that would detrimental the progress of this event. Ya Allah, Ya Rahman, Ya Rahim, please bless us with your tawfiq in hidayah. Make us as responsible intellectual person. Grant us with valuable knowledge that will be beneficial to mankind in order to gain your maradatillah. Make us your righteous servant that follow your commands and neglect the sinful act. Please forgive us from our wrongdoing. Ya Allah, Ya Malik, bestow peace to our beloved country Malaysia. Preserve us from any threat and disaster, neither man-made nor natural disaster. And to you, Ya Allah, we ask for security and prosperity upon us, our leaders and our country. Bestow patience in us in order to face challenge from you. Rabbana atina fid dunya hasanah wa fil akhirati hasanah وقنا عذاب النار وصلى الله على سيدنا محمد وعلى آله وصحبه أجمعين والحمد لله رب العالمين.
Thank you Encik Muhammad Zulhilmi bin Kamaruddin for the doa recitation. May this event run smoothly in these 2 days. Distinguished guests, ladies and gentlemen, without further ado, we would like to invite Yang Berusaha Dr. Haji Tahir bin Aris as the Chairperson of the Organizing Committee to deliver his welcoming address. Please welcome.
Thank you, Madam MC. Bismillahirrahmanirrahim. Yang berbahagia, Datuk Dr. Nur Fariza Ngah, Deputy Director General of Health, Research and Technical Support. Yang berusaha Dr. Morizal Zainul, Managers of the National Institute of Health, NIH Malaysia. Yang berusaha Dr. Muhammad Fairul Nizal Muhammad Noh, President, Ministry of Health, Researcher Association and Co-Chairperson Organizing Committee. Directors, Registrar of the National Institute of Health, distinguished speakers and delegates, honored guests, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh and very good morning to everyone. On behalf of the 24th NIH Scientific Conference 2023 Organizing Committee, we are pleased to welcome all of you, our old friends, colleagues, and we have known since the NIH conference began, and those who are new to the 24th NIH Scientific Conference. My utmost gratitude to Yang Berbahagia Datuk Dr. Nur Fariza Ngah, Deputy Director General of Health, for agreeing and being able to spend her time to officiate the opening ceremony. To this much awaited annual event, we believe the presence of Yang Berbahagia Datuk, Datin, distinguished invited speakers, conference presenter, and registered attendees today as a show of support and commitment to the research into healthcare of our nation. For the first time ever, we also open our door to the general public, surrounding companies and facility to attend this event, and we hope you will gain much in your visit to NIH. In this 24th NIH Scientific Conference, we have chosen the theme Health Research to the Public as a symbolic gesture to increase awareness and new finding to not open the conference to the public. We realize in this era of open communication and easy accessibility to information and aspiration of Ministry of Health that healthcare should be owned and shared responsibly both by the government and Malaysian as a whole. Therefore, the way forward is to share what we researchers found to be shared with Malaysian, young and old, so that we will be more informed in our healthcare choices. The journey that brings us here today has been marked by months of meticulous planning, dedication, and collaboration. Our team has worked tirelessly to curate a program that showcases the latest advancement in health research, spanning a wide array of discipline and perspectiveness. In this conference, the session will be divided into 3 clusters: biomedical science, clinical and public health, and health system management. Participants will have opportunity to engage in a robust discussion, to exchange ideas, to learn from one another, and to foster collaboration that transcends disciplinary boundaries. As an attendee, you will hear new knowledge being discussed in the oral presentation and dialogue in the plenary and symposium session that will be held in this auditorium Perdana and in auditorium 1. We are grateful for the willingness of the plenary and symposium speakers who are the subject matter expert in their healthcare fields to be able to come to share their current views and specific selection of health issues. There is also a large session displaying posters that contain huge number of research findings and conclusions being placed in the NIH ballroom. In this conference, you may spend as much time as you wish to see the poster that not only display recent research findings, but also findings that NIH researchers have accumulated over the past 5 years at the conference marketplace. Another unique offer from us is the presence of exhibition booth at the ground floor surrounding our infinite pond that show the role and scope of activity of the 6 NIH Institute. There are also information tables with presence of representatives from National Stem Cell Registry, Biobank, National Autism Society of Malaysia, National Kidney Foundation, National Diabetic Association to cater to inquiries. For the convenience of the public attendee, we hope that you could purchase food from the food stall organized by Puspanita NIH and purchase fruit from the pharma and pharmaco product in the support of local produce. To the researcher, we hope this conference will reduce the gap between scientific discoveries and translating the discoveries into some plan of action. Positive reaction and commitment to take better care of ourselves and our future generation and mother Earth. Let us have more constructive ideas and discussion and collaboration on healthcare issues between the researchers and stakeholders after this conference ends. As for the public attendees, we thank you for coming. We hope you will visit us again on IMR Open Day in October that we plan ahead. I would like to express my gratitude to Persatuan Penyelidik Malaysia, who has gratefully accepted the role of co-organizer of the 24th NIH Conference. This society has been a friend in need in providing financial support and constructive ideas to the planning of the event. I also would like to express our gratitude to our sponsor, Perkin Elmer, Our Life Chemo Farm, Biomedical Solution, Biomedical Lab, Water Analytical Instrument, Envu Malaysia, IKA, AQNAS, for a generous contribution to this event. To the NIH Organizing Committee, I am utterly grateful for your dedication and willpower to organize this event in the great speed. The commitment and teamwork shown by the committee member led by Dr. Raden Shamila and Dr. Mariana have been exemplary. Looking at the number of research participation and the public reception, I could not be proud. Shabas to all NIH working and scientific committee. Let us embark on this remarkable journey with a shared sense of purpose. May this conference serve as a stepping stone toward a future where health research to the people become a universal reality, empowering individual and community to take charge of their well-being. Together, let us make a difference. Thank you very much.
Thank you, Yang Berusaha Dr. Haji Tahir bin Aris for the welcoming speech. Ladies and gentlemen, may we now have the honor to invite Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah to deliver the keynote address with the title Health Research to the People and officiating the 24th NIH Scientific Conference 2023. Please welcome Yang Berbahagia Datuk.
Terima kasih pengerusi majlis. Bismillahirrahmanirrahim. Yang Berusaha Dr. Murizal Zainal, Manager of the National Institute of Health Malaysia. Yang Berusaha Dr. Tahir Aris, Director of Institute for Medical Research and Co-Chairperson Organizing Committee for the conference. Yang Berusaha Dr. Muhammad Fairunizal Muhammad Noh, President, Ministry of Health, Researcher Association and co-chairperson Organising Committee, all the directors and the registrar of the National Institute of Health, distinguished speakers and delegates, honored guests, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh and salam Malaysia Madani. First and foremost, I would like to take this opportunity to thank the Organising Committee for inviting me to give the keynote address on the health research to the people. I am honored to stand before you as we explore the critical role of research and its significance in improving the well-being of individuals and community worldwide. As we convene to this dynamic forum, we must recognize that the future of healthcare lies in our hands, in our collective pursuit of knowledge, innovation, and most importantly, in our commitment to serving the people. Before we get into a broader aspect of health research, allow me to share a story that reflects the potential and success health research for our country. As you can see in the slide, the Mentari Court, consisting of 18-floor high-rise residential blocks. It is a dengue hotspot in Petaling district, which usually has the highest number of dengue cases in Selangor. Every year, there are about 100 to 150 to 370 dengue cases at Mentari Court, making it one of the highest contributors to dengue statistics in Selangor since 2013. This issue affected the well-being of the community there. This mosquitoes-borne viral infection causes a range of symptoms, from a mild flu-like illnesses to severe hemorrhagic fever, and extreme cases cause death. There was fear and concern in the community due to the spread of the disease. People restricted their outdoors activity, which affected social interaction and community events. This disease also affected the socio-economic situation as high number of dengue cases led to increased absences for work and school, resulting in loss of productivity. Families had to spend extra on additional medical expenses, leading to the financial burden on household. Therefore, in October 2017, the Institute of Medical Research, IMR, launched an innovative dengue transmission blocking program using a Wolbachia as a dengue strategy to reduce dengue transmission, and Mentari Court in Selangor was one of the selected sites for the intervention. Wolbachia is a bacterium that which can be used as a form of biological control. It occurs in nature, is naturally occurring, and it can be found in 60 to 70% of insects, spiders, nematodes, and etc. It has effective, safe, and sustainable methods that has no undesirable effects on the environment. In this program, Aedes aegypti carrying Wolbachia are released into the environment to mate with their wild counterparts. All the offspring which carrying Wolbachia are therefore free of dengue virus. This program had successfully achieved a maximum reduction of dengue cases, approximately 70%, suggesting that this strategy successfully reduced local dengue transmission in Mentari Court. Today, although dengue cases in Petaling Street is still among the highest in Selangor, contribution of Mentari Court to this statistic has been significantly reduced. Consequently, this strategy has been implemented nationwide in dengue hotspot area. I hope this one of the success story from many can reflect the journey of the health research to the people. Every research begins with a spark of curiosity and unwavering commitment and dedication to pushing the boundaries of the body knowledge. By the investing in health research, our country can continue to foster better health for the people of today and for generations to come. Ladies and gentlemen, health is not just the absence of disease. It is a state of complete physical, mental, and social well-being. Access to quality healthcare and advancement in medical research have played vital roles in improving human life across generations. But there still remains an undeniable gap between the scientific breakthrough and their equitable dissemination to all members of society. Today, we come together to bridge that gap, to bring health research directly to the people. Health research is the driving force behind advancement in medicine, healthcare, and public health. From the discovery of life-saving treatment to the prevention of blindness, health research has transformed the landscape of global healthcare. As we delve into the theme of this conference, we must ask ourselves, what does health research to people truly mean? It's not merely about conveying complex medical jargon to the masses. Instead, it is about translating scientific knowledge into practical solutions that can be implemented in our communities, empowering individuals to make informed decisions about their well-being. However, despite its significance, health research has often been confined within the wall of academic institutions and research facilities. It is time to bridge the gap between the researcher and the people. We must make health research accessible to all, breaking down barriers that hinder the dissemination of knowledge and the implementation of life-changing findings. To bring health research to the people, first and foremost, we must embrace the importance of community-based research. Traditional research setting must not always reflect the diverse realities faced by individuals in their daily life. By engaging the communities directly, we can gain valuable insight into their unique health challenges, cultural nuances, and socio-economic factors that impact their health outcomes. This approach fosters a two-way streak of learning, where researchers can understand the community needs, and in turn, the community can be actively involved in shaping research priorities. May I bring our intention back to the World by Care project? The fundamental requirement for the successful implementation of any mosquito release program resides in the comprehensive education of the local community. This ensures a well-informed populace capable of understanding and appreciating the underlying objectives and strategies associated with mosquito release initiative. The community engagement efforts were undertaken by the Institute of Health Behavior Research in collaboration with IMR. This collaborative endeavor aims to foster an environment of interaction and information exchange between the scientific institution and the community, thereby facilitating the assimilation of knowledge and the establishment of cohesive partnership. Community members are cordially invited to IMR, where they were provided updates on the progress of mosquito releases and encouraged to actively participate in progress discussion, thus fostering a sense of shared responsibility and ownership. This collaborative exchange of information at designated venues such as IMR strengthen public participation in disease control endeavors. From the engagement session, the local community exhibit a positive acceptance towards the release of both male and female Wolbachia-infected Aedes aegypti mosquitoes for dengue control, and consequently, the project successfully implemented. Another good example of community-based research conducted by NIH is the Enhanced Primary Healthcare Study. This project involved various institutes within the NIH, such as Institute of Health Management, Institute of Public Health, Institute of Clinical Research, Institute of Health System Research, and Institute for Health Behavior Research, with emphasis on the non-communicable disease bundle of care, focusing on diabetes, hypertension, and hypercholesterolemia. This was conducted in 20 health clinics in Johor and Selangor in July 2017. This NPHC project under the Malaysia Health System Research Initiative is a collaborative effort between the Harvard University of Public Health and Ministry of Health Malaysia. This initiative tackled issue of NCD at its source by promoting preventive efforts, empowering each individual to take control of their own health and wellness, as well as increasing rapport between patient and their primary care doctors, ensuring a seamless transition of care for each patient between MOH hospitals and clinics. A total of 309,472 patients were enrolled, and 92,209 has been screened for the NCD risk. Ladies and gentlemen, another aspect of bringing health research to the people is we must embrace the concept of open science to ensure that our research truly benefits the community. Open science, a discipline focused on making research products including data, information, and knowledge accessible to everyone, extend beyond the boundaries of academia. In the spirit of collaboration that open science embodies, I'm proud to announce that MOH through the NIH has joined force to become one of the first agencies involved in an initiative conceived by the Ministry of Science, Technology and Innovation, namely the Malaysia Open Science Platform. This innovative initiative, recently launched by our Deputy Prime Minister, Yang Amat Berhormat Datuk Seri Haji Fadilah Haji Yusof on the 16 May 2023, stand on three pillars: developing a national research data sharing guidelines, providing a unified platform for diverse repositories, and fostering stewardship capabilities. This unwavering support by MOH for this initiative is exemplified by the active role played by NIH in data stewardship training and its strategic plan to merge its existing NIH data repository or NIH DARS with the MOSP platform. By wholeheartedly embracing open science, we are set to empower healthcare professionals, policymakers, and citizens alike, thus enabling them to make well-informed and evidence-based decisions regarding their health. Also, a crucial aspect of bringing health research to the people is promoting health literacy. Empowering individuals with knowledge and understanding of health-related information equip them to make informed decisions about their own well-being. We must encourage accessible and reliable sources of health information to foster a healthcare literate society. In National Health and Mobility Survey 2019, it was found that overall health literacy status among Malaysian adults was categorized as low sufficient level. More than 1/3 or 35% of them has limited health literacy. The rate of health literacy can be improved through the provision of information, effective communication, and structured education. However, to enhance all-inclusive population-based health literacy capacities, I think we need to properly address social determinants of health comprehensively that are beyond the Ministry of Health boundaries. There is a real need to develop, implement, and evaluate programs and intervention to improve knowledge, understanding, and the capacities to act on social, economic, and environmental determinants of health at large. Realizing that all these important aspects to improve public health literacy level, MOH has developed the National Agenda for Healthy Malaysia, or ANMS, Agenda Nasional Malaysia Sihat, for a period of 10 years, beginning from 2021 to 2030, to foster a culture of healthy living by improving people's health literacy. It hopes that this will enable more Malaysians to take responsibility for embracing a healthy lifestyle, and NMS adopt a whole-of-nation approach involving government agencies, non-governmental organizations or NGOs, the private sectors, as well as the people, to ensure successful implementation in making the people's health and well-being a priority. Moreover, under the 12th Malaysian Plan, MOH is developing a national health literacy policy, which includes a surveillance system through the development of Healthy Lifestyle Index. IPTK played an important role in both initiatives being a center of excellence in health behavior research in the country. Ladies and gentlemen, in this digital age, technology plays a vital role in advancing health research and improving health outcomes. From wearable devices to telemedicine, cutting-edge technologies open new avenues for data collection, data analysis, and treatment delivery. Telemedicine, health apps, and digital health platforms bring expert advice and medical resources to remote and underserved areas, breaking down barriers of distance and accessibility. the digitalization of medical records, real-time health monitoring, and telemedicine are already reshaping healthcare. By harnessing the vast amount of data generated from these sources, we can gain valuable insight into disease patterns, treatment outcome, and public health trend. For example, the usage of MySejahtera as a digital tool during the COVID-19 outbreak enabled us to monitor disease spread in the community and individual disease progression. This in turn enabled us to make informed decisions, allocate resources effectively, and design targeted intervention that have tangible impact on the well-being of the citizen. NIH supported this role where Biomedical Epidemiology Unit, IMR, provided the daily estimation of COVID-19 reproduction number, the R0 ratio RT at the national and state level, which was integrated into the MySejahtera mobile application and MOH official COVID-19 website available for public information. Now, as we are moving towards precision medicine, digital health technology such as Internet of Things, the artificial intelligence, and innovation, and MOH researchers involved in clinical trials. At ICR, a digital health research and innovation unit was established recently to spearhead the health research under this area. Again, I'm proud to share that despite they are still in infancy years, the unit has won Innovation Award. They won the first place in Malaysia MOH Innovation Award 2022 for a project COFI, a cough sound artificial intelligence for detection of COVID-19. This innovation could be used by the people or by rakyat to screen for COVID-19. Also, we have several NIH innovations that have been in the market and used by the public. For example, MyMed Aedes mosquito autocidal trap, developed by IMR, has been utilized by Malaysian, European countries, and Middle East countries since has been launched by Deputy Minister of Health in 2016. Ladies and gentlemen, in the era defined by rapid advancement in science and technology, collaboration has emerged as an indispensable pillar for progress. It is a key to unlocking the full potential of health research. The complexities of health challenges we face today, from infectious disease to chronic condition, transcend boundaries and demands of a unified approach. No single institution, organization, or nation possesses all the resources, expertise, and perspective required to address this intricate issue in isolation. By fostering interdisciplinary collaboration between researchers, institutions, governments, private sectors, and community, we pave the way for a collective intelligence that is more than a sum of its parts. Collaborative research enriches the scope of inquiry and generate knowledge. We must also commit to share this knowledge openly and equitably. Access to information is a fundamental right. It is through collaboration that we can ensure that the benefit of our collective efforts reach every corner of the world, leaving no one behind. Since the sixth National Institute of Health shared the same compound in 2019, we have seen an exponential increase in the numbers of collaborative projects between this institute, especially projects that exploited each institute research forte. For example, the preclinical, which involved the laboratory, clinical trials, surveys, health policy and system, health management, and health behavior. I pray for smoother integration of these collaborative efforts for years to come. Let us remember that collaboration is not limited to scientists and researchers alone. It involves policymakers, healthcare providers, educators, philanthropists, and more importantly, the individuals whose lives stand to be improved by our endeavors. As we forge collaborations, we must actively seek to engage communities, understand their needs, and empower them with the insight derived from our research. However, the path of collaboration is not without its challenges. It requires us to transcend personal ambition and organizational boundaries. It demands effective communication, mutual respect, and willingness to listen and learn from each other. Yet, in facing these challenges, we demonstrate our commitment to a higher cause, the advancement of health and well-being of all. Effective research must be supported by robust policies and advocacy efforts. As a society, we must recognize the importance of evidence-based policy making to drive positive health outcome. Nevertheless, in an era of abundant information, it is easy to become overwhelmed by data and opinion. Therefore, evidence-based policy making offers a clear path through this maze of information. It hints on the principle of grounding decision in sound research and data analysis, ensuring that policies were designed are not well-intentioned but also grounded in proven effectiveness. By fostering a strong partnership between health researchers and policymakers, we bridge the gap between the theory and action. Robust research findings provide a solid foundation upon which policies can be constructed, offering a tangible roadmap for addressing health disparities, preventing diseases, and improve overall well-being. This collaboration between the world of academia and the world of governance is where transformative change is born. Investment in health research is an investment in our future. Governments, philanthropists, private sectors must increase their support for research funding. This investment has the power to unlock the doors to new discoveries, innovative treatments, and breakthrough intervention that can transform lives. When we allocate resources to health research, we plant the seeds of knowledge that we grow into healthier, happier communities. Moreover, investing in health research is an investing in equity. It ensures that advancement in healthcare benefits all members of society, regardless of their socio-economic status, geographical location, or background. As we delve into research that focuses on diverse population, we uncover insights that help us address health disparities and deliver care that is inclusive and accessible to everyone. As we contemplate the importance of investing in health research, let us recognize that this investment is not solely financial. It's an investment in hope, in the potential for brighter and healthier tomorrow. It's an investment in the empowerment of individuals to lead fulfilling life, free from burdens of preventable disease. Ladies and gentlemen, in conclusion, health research to the people is not just the theme for this conference. It is a rallying call for profound societal transformation. By integrating research into our daily life, by sharing knowledge freely, and by empowering communities to be active participants in their life, we pave the way for healthier and more equitable future. Let us renew our determination, armed with the conviction that health research is not an abstract concept, but a powerful tool for positive change. Together, let us work tirelessly to translate health research into action that touch the lives of people, leaving behind a legacy of improved health for generations to come. I would like to take this opportunity to congratulate the chairperson, members of the organizing committee and scientific committee, the directors, managers, registrar of NIH, and those who contribute directly or indirectly on this conference on their dedication and commitment to this organizing meaningful event. On that note, it gives me a great pleasure to officially open the 24th NIH Scientific Conference 2023. Thank you.
Thank you, Yang Berbahagia Datuk. Yang Berbahagia Datuk, please remain on stage for the next agenda. Next, we would like to invite Yang Berusaha Dr. Haji Tahir bin Aris and Yang Berusaha Dr. Fariza bin Zainul to come together on stage with Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah for the opening gimmick. Please welcome. Ladies and gentlemen, may we now invite Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah to strike the gong to mark the opening of the 24th NIH Scientific Conference 2023. With that marks the officiation of the 24th NIH Scientific Conference 2023. Thank you Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah, Yang Berusaha Dr. Haji Tahir bin Aris, and Yang Berusaha Dr. Murizal bin Zainul. Ladies and gentlemen, that concludes the opening ceremony of the 24th NIH Scientific Conference 2023. On behalf of the organizing committee, we would like to express our utmost gratitude to Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah and all participants for making this event a success. We would like to invite Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah and our guests for a scientific and marketplace poster viewing located at the NIH Ballroom and the ground floor concourse, Block D2. For all participants, we will now be having a 30 minutes break. Please be back at this auditorium for the plenary 1 session at 10:30 a.m. And before the departure of Yang Berbahagia Datuk Dr. Nur Fariza binti Ngah, may we have a photography session with all the participants in the hall. We would like to ask your cooperation to stand at the center of the hall for the photography session. I'd like to call upon the chairperson for this plenary one, Dr. Julaina Abdul Jalil, Head of Inborn Error in Metabolism and Genetic Unit, Institute for Medical Research, IMR, and the speaker, Dr. Ngu Lock Hock, Consultant in Clinical Genetics and Inherited Metabolic Diseases, Hospital Kuala Lumpur, to come on stage. Please welcome.
Thank you very much, Madam Mistress of Ceremony, Dr. Nurozawani, for the kind introduction. Now we move on to the first plenary session for this NIH conference to 2023. Firstly, I would like to welcome everyone to the first plenary session of NIH Scientific Conference 2023. And for those coming outside of the NIH, welcome to our NIH, a very distinguished building. And before we start, I just would like to remind Dr. Ngu, the allocated time for this talk will be 30 minutes, 25 minutes for lecture and 5 minutes for Q&A session. And Dr. Christina over there will be alert us on the time. And our first plenary speaker today, Dr. Ngu, need not further introduction to me personally, as I have known him for more than a decade ago. But today I would like to introduce him to the audience before he delivers his talk. Dr. Ngu Lock Hock holds professional qualification of MBBS Malaya since 1997, membership of Royal College of Physicians UK in 2000, and fellowship in clinical genetics Malaysia in 2003. As part of his training, he also spent 1 year at Nijmegen Center for Metabolic and Mitochondrial Disorders, the Netherlands in 2006. And currently, he is the consultant clinical geneticist and pediatrician and the clinical lead in inherited metabolic diseases at the genetic department of HKL, Hospital Kuala Lumpur, which serves as the National Referral Centre for Inherited Metabolic Diseases and Genetic Disorders in Malaysia. Dr. Ngu is the medical advisor of the Malaysia Lysosomal Diseases Association, a support group for lysosomal disorders. He has published more than 80 manuscripts in peer-reviewed journals in the field of genetics and inherited metabolic diseases. He has also been an invited speaker at over 100 local and international events and has presented over 100 free papers since 2003. He has been an invited reviewer for international journals as well. He is a member of vast committees internationally and locally, including the Malaysia Ministry of Health Clinical and Supportive Management of Rare Disease Working Committee, Newborn Screening Committee, Technical Committee on Enzyme Replacement Therapy for Lysosomal Storage Disorder, and the Expert Committee on Orphan Drugs, and also Asia-Pacific Mucopolysaccharidosis MPS Network. He is the principal investigator at HKL for a number of clinical studies, co-investigators with several research studies, including with IMR, and the current chairman of HKL Research Review Committee. Without further ado, I would like to invite Dr. Ngu Lock Hock to the stage to deliver his talk entitled The Advancement of Treatment and Medical Setting for Patients with Rare Disease.
Good morning. Thank you, Dr. Julaina, for the very kind introduction, and also invite me for this event today. So I will share my experience on rare diseases. Next slide, please. So rare disease refer to complex diseases with very low prevalence or incidence rate. So different jurisdictions have different definition. WHO define as if the prevalence is 6.5 to 10 per 10,000 population. In European Union, they define as 5 per 10,000. So in Malaysia, we define as 1 in 4,000. That's our official definition by the Ministry of Health. Next slide. So in Malaysia, we keep official list of rare diseases. So currently, there are about 500 diseases listed in this official list that's maintained by the Ministry of Health. Next. So there's certain criteria to be listed under this Malaysian rare disease list. There must be a confirmed patient in Malaysia, and incidence is less than 1 in 4,000. And the disease must be a severe condition, and the inclusion is approved by the National Advisory Committee, which is the National Rare Disease Committee in the Ministry of Health. Next. So some key statistics of rare diseases. Currently, there's more than 6,000 non-rare diseases, and about 5,500 are listed in the ICD-10, ICD-11, and each year is reported there are addition of 250 new rare diseases. And individually, each disease are rare, but collectively they are not rare. Its estimated affects more than 350 million people worldwide, and more than 2/3 of these rare disease have a genetic basis. Of course, there's some others causes of rare disease, including rare infectious disease, rare autoimmune disease, and others. 70% of these rare disease started in childhood, but adults are not spared. And only 5% of these diseases have some form of disease modifying treatments. Next. So even when the disease have a disease modifying treatment, it often very costly. You can see from this diagram here. There's in the recent year there's a lot of global interest from pharmaceutical company to develop some of these orphan drugs for the rare diseases. By 2030, it's estimated global orphan drugs market will reach about more than 400 billion US dollar. And obviously, this may be a crisis because the healthcare around the world may not have enough money to treat all these rare diseases. It may also provide or present opportunities. Next slide. So for examples, currently we just launched this clinical trial for a very rare condition known as fibrodysplasia ossificans progressiva. This is a very rare condition where the affected individual, the muscle will turn into bone because of the genetic defect. So we are one of the only clinical trial center in Southeast Asia, and one of the very few in the world. So there is opportunity besides high cost. Next slide. So traditionally, when a doctor's clinician meet a patient, we try to figure out what's a likely diagnosis and do a test to try to test whether this diagnosis is proven or not. So if we cannot find a diagnosis, we will refer to as another specialist maybe from the different discipline to try to figure out what is the underlying cause, and then he or she will do the same thing, try to do some tests to prove or disprove a diagnosis. So a lot of time this will go on and on and on, and very often rare disease patient may need to see many specialists before the final diagnosis is known. So this is classically known as diagnosis odyssey, whereas frequently faced by many rare disease patients, not only in Malaysia, in similar scenario worldwide. Next. And I just illustrate this point by presenting to you a very interesting family. So this is a consanguineous family. There is 2 affected siblings in this family. Next slide. So the first sibling, he presented with chronic diarrhea during infancy, resulted in failure to thrive and recurrent. In addition, he also had recurrent infection, hepatomegaly. There's the liver specialist actually performed a liver biopsy, which sure that histologically he had this hepatitis picture. His liver enzyme all are raised. So then when he reached school-going age, he appeared shocked and had mild learning difficulty. He had to be placed in the special class. And moving on, he develops poor vision. That's why referred to ophthalmologist, who also found that he had nystagmus, squint, and he had this what we call Pitots spot, which indicate there's a dry cornea. And then when he reached puberty, parents request a circumcision. So we do a pre-op assessment, found out that he actually had coagulopathy, which is somehow correctable with vitamin K. So until this stage, we don't know what is the underlying diagnosis, despite many tests being done, all the routine tests, liver ultrasound, liver biopsy, metabolic screen, infected screen, sweat test for cystic fibrosis, autoimmune screen, nothing come out diagnostic. So until he turned 16 years old, when we had an opportunity to perform a whole exome sequencing for him, then we finally find out what is the underlying diagnosis. By this time, he already develops ataxia, unsteady gait, and his MRI shows this Kyrie malformation, type 1 or hydrocephalus, and cervical syringomyelia. Next slide. So this is similar to his sibling, almost identical sort like presentation during the infancy, except he also have a recurrent vomiting that require frequent hospital admission. He also had dry skin, some skin problem, specifically follicular keratitis, short stature, learning difficulty, coagulopathy, similar eye finding, and also neurological involvement where he developed epilepsy. He had this psychotic symptom, requires psychiatric treatment. We have the whole exome sequencing done at the same time as the elder sibling. Next. So for the whole exome sequencing, we found there is a homozygous variants, pathogenic variant, likely pathogenic variant in NTTP gene, and this is have a variant that causes a loss of protein function, and their final diagnosis is A beta lipoproteinemia. So obviously, in medical school, we did heard about this term, but in real life, I think not many of us have seen such cases. Next slide. So it took us 16 years to finally realize that they have this diagnosis, and this is a very rare condition, autosomal recessive inheritance, incident less than 1 in million worldwide, and because of deficiency of a microsomal triglyceride transfer protein, and they had this fat malabsorption, interfere with absorption of fat soluble protein, the ADATE that we we know in the school. Next slide. And look at the textbook. All these patients were A beta lipoproteinemia, were present with failure to try, diarrhea, vomiting, steatorrhea, hepatomegaly, vision problems, retina, pigmentation, abnormality, ataxia. So everything they have. But yes, as a clinician, we have problem to recognize that. Okay, next. So look at the lab result. Also very interesting. He had this slightly low total cholesterol and TG. Yes, he has seen many specialists. We didn't recognize this. We are good in looking at something very high level, but we're not good in looking at something is deficient. So again, we miss all this clue. Next. Okay. So fortunately, not too late. We still can provide some medical treatment by managing their diet, cut down the fat intake, supplements the essential fat, fatty acid, supplements the fat-soluble vitamin. So with that, their disease has stabilized. But of course, whatever damage that have happened, that probably is not reversible. Next slide. So the lesson from this family is clinical diagnosis just based on the clinical features. It may be very challenging for patients with rare diseases because there's so many rare diseases. There's no clinician able to recognize all the clinical features that associate for all the different rare diseases. And we learn from our previous experience. If we don't see a case, we probably will not be able to recognize. And so worldwide, there is this development where people start considering whole exome sequencing at the first line of testing. So if we look at the quick search in the PubMed, you can see that over years, the number of publications that advocate this initiative increasing rapidly. Every year, there's 20 to 30 articles being published to advocate whole exome sequencing as first line of testing. This is especially important for the patient with complex clinical phenotype, patient with unexplained multi-system symptom and sign, just as the family that I have presented to you. And also equally important for patients who is acutely ill in ICU without a diagnosis, because you need to quickly find a diagnosis whether there is a treatable condition before the time is running out. And obviously, there's a debate whether it's WES or WGS, whole genome sequencing, which one is better. So at this moment, considering cost factor, probably the whole exome sequencing is more economy, more cost effective, because the cost is much lower as compared to WES, and the information that you can gather from the testing is not that inferior to whole genome sequencing. Next. And this is not a dream. So some healthcare, like in UK, already in their pipeline, whole genome sequencing will be part of their routine care. There's already a plan as such to use this genomic testing as a routine in their routine clinical care. So obviously, we don't want to be left behind for all this advancement. Okay, next. So obviously, we do have our own challenges. Okay, obviously, there's a cost to establish this sequencing facility. We need trained expert, scientists, clinician. We need some regulatory framework to make sure that this is done properly. Put the patient interest at the top priority, and we can do it in-house, outsourced to the private facility. But our challenge is the local outsourcing services. Their quality is not there, at least at this moment. Next. So we do need a big data. So if you so variance allele frequency is one of the very important data set that we require to analyze all these genomics testing result to determine whether the variant is pathogenic or not. So if we only rely on those data sets that are available publicly, free of charge, well, we're happy, but those are not complete. They are not, for example, in the genome Asia, only very few Asian, don't say Malaysian, is included in the data set. So they are probably not representative for our population. Okay, so we do need to do something. So in many countries, especially those developed countries, they do have their national genome project where they gather all this data from their population, because you do need any specific data for some of this purpose. So over the past 3 years, we do have collaboration or a foreign laboratory, 3 billion, which is a certified laboratory. So we do a lot of whole exome sequencing on a collaborative basis as well on the commercial basis. So we do have more than 3,000 WES data in this laboratory. So currently we're in the process to bring back all this raw data so that we can make use of this data to train people in our own country to come out with our own data, so that we can develop this expertise in Malaysia. And I must acknowledge the content of this slide is with the help of Dr. Nizam from NIH, and as well as the subsequent 2 or 3 slides. Next. So, so another things we can do if we bring back this raw data is we can reanalyze some of the exome negative cases by using different analytical tool, and then to find whether there's a diagnosis of all these exome negative cases. Next slide. So as we may be able to develop a next generation phenotyping technology that more specific to Malaysia. These are technology already available. So we have certain apps, certain tools that can use to complement the clinician to make diagnosis. Because in making a diagnosis, we need to recognize any special features, especially the facial features, and there's limitation as clinician unless we see a case before. Otherwise, we cannot recognize it. Okay, that's why there's this initiative to use AI, to use this next generation phenotyping to assist the clinician to make an early recognition, early diagnosis. And obviously, a lot of this data, a lot of the apps, their patients are Caucasian. So it's not the same for Malaysian. So we need our own data. So, so that's what we hope to achieve if we can bring back all this raw data. We have over 3,000 whole exomes raw data. And next, I will quickly move to the therapeutics area for rare diseases. Obviously, over the past few decades, there's a lot of advancement. There's many types of modality available, either a small molecule, the protein replacement, or antibody, or oligonucleotides therapy, or in future, cell of gene therapy. So different disease, they may have different therapeutics modality, either targets at the protein, or RNA, or DNA. Next slide. Next slide. So just, can you click on the video? Just tell you a story for these 2 siblings. So I saw them 5 years ago. They are like this, lying on the back, very minimum movement. They are diagnosed as cerebral palsy. So they are referred to me. I say, I don't know what is the diagnosis. So let's do a whole exome sequencing because the parent can afford. Okay, so this is the very first whole exome sequencing I did at that time. So after that, we did find a treatable condition. You can click the last two video. So what treatments? Their life has changed. So now they can walk. From bedridden, they can have children that are able to walk. Okay, next slide. So what is their diagnosis? They have this condition called tyrosine hydroxylase, which is an enzyme that required to make our neurotransmitter dopamine. So without dopamine, our motor neuron doesn't work. So you need to replace this missing neurotransmitter by providing the precursor that bypass the enzymatic block. This drug is available. This is cinnamon L-DOPA is used to treat Parkinson's disease. So we can repurpose an existing drug for treatment of rare disease. Not all rare disease require expensive treatment. Sometimes you can find an existing drug, just repurpose it for treatment of rare disease. This is classical example. Next slide. So I have lots of experience in treating lysosomal storage disease, which is a group of more than 50 different genetic diseases due to enzyme deficiency in the lysosome. Next slide. So about 20, 30 years old, we know this basic biology, basic science about lysosome, where this lysosome enzyme, how they've been targeted to the lysosome. That's because in the Golgi, this lysosome enzyme will be tagged with amino 6-phosphate molecule. And this carrying vesicle organisms machinery had this amino 6-phosphate receptor that capture all these enzyme label or tag with the amino 6-phosphate molecule, and then endocytosis into the endosome that make sure become lysosome. So by understanding this basic science, then we can develop a treatment for this lysosomal storage disease using genetic engineering and bioengineering. So whatever synthetic enzyme that we manufacture using genetic engineering, we need to chemically modify by tagging them with the amino 6-phosphate. So just then mimic the in vivo function of the enzyme, how the enzyme been trafficked into the lysosome. Next slide. So currently we have more than 10 different products for this lysosomal enzyme, lysosomal storage disease. Next. And it's still rare disease, but not uncommon. We have over 200 patients in HKL. Most common is MPS, and most common MPS or MPS type 2. So currently we have close to 60 patients on enzyme replacement therapy. So all the enzyme products that I listed just now, all are being used in this country. So it's not a dream, it's possible. Next slide. So this is some of the patients that we have treated with enzyme replacement therapy. This is a Pompe disease, infantile type of Pompe disease. Without treatment, they actually don't survive more than 2 years old. This child is 5 years old. The other one is celebrating 18th birthday. And the one on the left is MPS type 4A. He had low degree working at a publication company at the moment. The next one is MPS type 6. He has his graduate of business management degree from University Udara, Malaysia. MPS 2, he currently taking this TVET in computer, and these two are our very lovely MPS type 1 patient. Next. So we do document some of the experience. This is our latest publication in collaboration with Dr. Juliana. describing our experience in treating and diagnosing patients with Pompe disease. Next slide. And obviously, enzyme replacement therapy intravenously, they still have challenges because they don't cross the blood-brain barrier. So we do need to other type of treatment. Next slide. And lastly, I will talk about spinal muscular atrophy, which often attracts attention from the politician recently. So this disease is no more than 100 years, but only about 30 years ago, the gene was discovered, which is SMN1 gene. Next slide. And there's a spectrum of clinical severity. The most common is type 1, which is usually without treatment, they cannot live beyond 2 years. Next slide. And currently, there's 3 licensed treatment. One is gene therapy. The other two is interfere by enhancing the pseudogene, the SMN2's function. Next. And of course, all this treatment, you need to start early to be more for the better outcome. So newborn screening is very important so that you can diagnose them in the pre-symptomatic state. So currently, we have a research project for NIH, Dr. Julaina and colleague, to try to develop a simple, user-friendly newborn screening kit so that we can apply this to our population, not only in Malaysia, maybe in other low-income, middle-income country. Next. So lastly, this is our standard of care for all the rare inherited metabolic disease, all the special milk. So for past 20 years, we have been providing our patients all this treatment, but we are in a very vulnerable position. For the past 2 years, we face a lot of challenges because there's a global shortage in this special milk supply. So even we have money, we have budget, we try to purchase it. But we was often told Malaysia is not a priority. Our product priority is for the European market, for North American market. So until today, we're still facing challenges to purchase all this product. Even we had the money, okay, because we are not in the priority list. Next slide. So that's kind of my conclusion. Rare disease management is challenges for our healthcare, but it also opens up opportunity. So, but it's very critical. We need to acquire all the strategic knowledge, either science, technology, or even the manufacturing capability, okay, to safeguard the interest of our local patient. And for this, all the stakeholders, whether you're a physician, diagnostician, academician, or researcher, or whatever, we need to work together. So a disease may be rare, but the hope should not be. So with that, I end my talk. Thank you for your attention.
Thank you very much, Dr. Ngu. There was indeed a very comprehensive and informative talk, and it's very enlightening to know that currently there are many advancements in the management of rare diseases, for example, of the lab investigations, NGS, and treatments, which has shown to contribute for a better outcome in patients with this type of disease. So due to time constraint, I think I will not allow any question to Dr. Ngu. Anyway, if there's any burning questions, you can keep in touch with Dr. Ngu through me and my team in IEM and Genetic Unit. So I think with that, it ends our first plenary session. Please join me to thank Dr. Ngu in a usual manner. Thank you, Dr. Ngu.
Thank you, Dr. Julaina Abdul Jalil and Dr. Ngu Lock Hock for a very informative and eye-opening session. As a gesture of appreciation, we would like to invite Dr. Muhammad Farul Nizam Matno to present a memento to Dr. Julaina Abdul Jalil and Dr. Ngu Lock Hock. Please welcome Dr. Ngu Lock Hock. Dr. Julaina Abdul Jalil. Thank you, Dr. Muhammad Farinizal Matno, Dr. Julaina Abdul Jalil, and Dr. Ngu Lock Hock. Ladies and gentlemen, may we now proceed with Symposium 1 with the theme Biomedical Research Connecting the Dots for Health. Our moderator for this session is Dr. Ravindran Thayan Sukumaran, Head of Infectious Diseases Research Center, Institute for Medical Research, IMR. And the speakers are Dr. Masita Arif, Head of Allergy and Immunology Research Center, Institute for Medical Research, IMR, Dr. Rozainani Muhammad Zain, Head of Virology Unit, Institute for Medical Research, IMR, and Dr. Muhammad Rizwan Muhammad Abdul Razak, Head of Bioassay Unit, Institute for Medical Research, IMR. Please welcome our experts on stage.
Thank you, Dr. Zawani, Madam Chairperson. Very good morning, everyone. Very good morning, everyone. Welcome to the Symposium 1 of the 24th NIH Scientific Conference, Health Research to the People. The theme of this first symposium is entitled Biomedical Research Connecting the Dots for Health. With us, we are very lucky to have three distinguished speakers who will share their research findings as well as their experience right from biomedical research that is on the way to be translated into the benefit, basically. So they will be sharing about the vaccine research as well as point of care testing development as well as therapeutics for natural product for therapeutic. But before that, I need to share some housekeeping rules. Each speaker, because this whole symposium is only 1 hour, so each speaker is only given 15 minutes. And Dr. Christina, who's strategically located right in front of you, will indicate to you to keep time when there's only 5 more minutes left, as well as 2 more minutes left. And as soon as 15 minutes up, your time is up. So to ensure smooth smooth flow of this symposium, I would like to appreciate that the Q&A session will be at the end of the session. Basically, that means the Q&A session will be at the end of the three presenters. So with that, I would like to introduce you the first speaker, Dr. Masita Arif, who is actually the Head of Allergy and Immunology Research Center, IMR. She obtained her master's in pathology, microbiology, and immunology at UKM in 2008. She's currently a consultant pathologist for medical microbiology and immunology. She's involved in more than 40 research projects focusing on allergy, autoimmune disease, transplantation, immunology, tropical infection, and so on. And she's also involved in, currently she's involved in many research pertaining to COVID-19 immunity, and she's now heading the R&D for COVID-19 mRNA vaccine in IMR. With that, I would like to welcome Dr. Masita to deliver her talk on current status and local vaccine development. Thank you.
Thank you very much, Dr. Ravi, for your kind introduction. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all the participants for NIH Conference 2023. Today I will present a title for my presentation, Current Status on Local Vaccine Development. I would like also to share here about the what I call our current status on vaccine development. And my slides here also, I would like to acknowledge the Malaysian Vaccine Project Office that I've shared the slides from them also. So in terms of outline of my presentation, these are the outline. I will talk about the lesson learning during the COVID-19, history of outbreaks in Malaysia, the National Vaccine Development Roadmap, and about our Malaysian vaccine development activities. So next. So what are vaccine? I'm sure all of us know that vaccine are products which are able to elicit a specific immune response that mimics the infectious agents, but they do not cause harm to the host. And this is the most successful and cost-effective public health intervention, resulted in the global eradication of smallpox and regional elimination of polio and measles, and vaccines saved the lives of over 2 to 3 million children each year. Next. So lesson learned during the COVID-19, as we all know, vaccines are the key public goods to save life. And COVID-19 proved that vaccines can be developed in a very short time when stakeholders make a concerted effort. And large public investments and joint planning of clinical development regulation, manufacturing capacity and innovative platforms were key enablers for fast vaccine development. Next. In terms of the history of outbreaks in Malaysia, we have Nipah in 1998, SARS 2003, and also we have 2004 HPAI, MERS-CoV-2 in 2014, 2016 Zika, and the recent one, of course, 2019 COVID-19. Next. So what are our future pandemics? Hopefully there's no future pandemics, but I'm sure because of our climate change, this cannot be still. There is a risk of to be happen. So in terms of the risk of zoonotic outbreaks, it can be from our can be either from our domestic animals, from the wildlife, and even our what you call Malaysian Nipah virus outbreak in 1998 to 1999. This is like very dangerous outbreak, which 75% mortality rate, and still again until now there is no vaccine. A virus with no vaccine. Next. And we know that in terms of the global and national market overview, there are billions of market value for this vaccine development, and a significant increase vaccine producers in ASEAN, as currently there are 4 countries with manufacturing capabilities such as Vietnam, Thailand, Singapore, Indonesia. So what about us in Malaysia? Next. Because of this, there is a launching of the National Vaccine Development Roadmap, or NVDR, and transformation of Malaysian Genome and Vaccine Institute, MGVI, on the 1st November 2021 by our, during that time, the Prime Minister, Datuk Seri Ismail Sabri. And from this, through the implementation of NVDR and establishment of MGVI, highly skilled human capital in various fields of research, especially those related to healthcare and vaccines, can be produced. Next. So in terms of the Malaysian strategy in preparing for the next pandemic, NVDR aspiration to make Malaysia self-sufficient in vaccine manufacturing and research development within 10 years. And the objective to develop a national roadmap that enables stakeholders and the government to understand the current scenario and gaps within the vaccine industry, and to formulate all these strategic plans to enable Malaysia to become a vaccine-producing country. Next. So these are the governance of National Vaccine Development Roadmap. It is chaired by the National Steering Committee on Vaccine Development, or NASCOV. And this is actually 2 ministries involved. The Malaysian Vaccine Sectorial Working Group, MVSWG, involved with Ministry of Health Malaysia and also Ministry of Science, Technology and Innovation, MOSTI. And both the Secretary General of MOSTI and MOH become the chairman of the committee. And from this, we have 3 main what we call office or secretariat. The first one, Malaysian Vaccine Project Office, MVPO, by MOSTI. They have various clusters. Here, the inside the MVPO, cluster funding ecosystem development, cluster halal vaccine development, cluster clinical trial capabilities, cluster vaccine production and logistics, and cluster vaccine research and development by NIBM MGVI. And from this MGVI, we have expert council consortia, ECC. The expert council consortia can be vaccine discovery, clinical studies, clinical trial, and process development. The second subcommittee is a Vaccine Collaboration Network, or VCN. This is chaired by Deputy Director General of Health, Research and Technology Support, MOH, and the members are various ministries and also the private sectors and also NGOs. And the last one, crisis and pandemic response. Next. So the governance of this MGVI we led and centralized under National Institute of Biotechnology Malaysia, while the activities will be conducted in decentralized facilities to leverage on existing capabilities such as Institute for Medical Research to conduct vaccine discovery research because we have BSL-3 lab, Institute for Clinical Research Malaysia and hospital, experience and expertise in conducting clinical trials, University Research Centre to conduct vaccine R&D, MGVI to conduct vaccine discovery and also support the sequencing, IFARM and IMR, and also Veterinary Research Institute facility capabilities to conduct animal studies and manufacturers, facility to contribute to process development. Next. So the roadmap have 6 strategies. The first strategy is governance, to establish an efficient governance model on vaccine-related activities. Secondly, to build manufacturing infrastructure, a privately driven and export-oriented vaccine manufacturing infrastructure. Strategy 3, clinical trial, to enhance guidelines and procedures related to regulation during the clinical development of vaccines. Strategy 4, human capital development, build a sufficient human capital capacity to develop the national vaccine manufacturing ecosystem. Strategy 5, vaccine technology acquisition and development. And strategy 6, for vaccine communication. Next. So in terms of the vaccine, Malaysian vaccine development ecosystem, the current capabilities for addressing pandemics, for the R&D, we have establishment the MGVI, function as the National Vaccine Research Centre to support vaccine research for new infectious diseases. And we also have this, for all the studies, we have what we call grant, Dana Pembangunan Vaksin Negara, DPVN grant, to support the vaccine R&D. We also have the training grant for upskilling in vaccine development ecosystem. And Malaysia is also involved in the Coalition for Epidemic Preparedness Innovation CEPI network. And we have the facilities apart from MGVI, IMR, University Research Centre conduct the vaccine R&D, Institute Clinical Research and Clinical Research Malaysia to conduct clinical trial, including the first in human clinical trial, BRI, IFARM and Serum to conduct preclinical. And we also have the vaccine manufacturing. Only 2 companies currently have the field and finished manufacturing. Next. So the current challenges for addressing pandemics, in terms of the challenges in R&D, of course, is do not guarantee development of a product, does not match with the local industrial business plan, and sometimes time consuming and costly. And another challenges is incentive challenges, no allocation for continuation high impact grant under RMK12 to MIDA, existing incentive doesn't match the current manufacturing needs, and no government agencies providing incentive on this pathway. And also economic challenges, demand for MOH for sustainability and support and small market. Next. So here I would like to share a few activities. Few activities in Malaysia vaccine development activities. Next. In terms of, according to our strategy, strategy 1 governance, we have a Malaysian Vaccine Sectoral Working Group, MVSWG meeting headed by the Secretary General of MOSTI and MOH. And we also have a Malaysian Vaccine Project Office headed by Dr. Azlan in MOSTI, as you can see on the picture. This MVPO also help us in Vaccine Collaboration Network, VCN, where it's headed currently by Datuk Dr. Fariza. And these are the features when we have a meeting in IMR. Next. In terms of governance also, we have this, what we call expert council consortia. All the vaccine experts can evaluate the projects for grants and also for training. And recently we have a technical working group for vaccine development candidate headed by the Director of Disease Control, MOH, where we need to know what are our priority of vaccine that we will need to develop. Next. For the strategy to NVDR manufacturing infrastructure, there are few companies actually already like having MOU. For example, Pharmaniaga Bionet Asia to develop hexavalent vaccine for children. And then the Solution Group, Casino COVID-19 inhalation vaccine, they have also this manufacturing infrastructure. And the Pfizer with Malaysian Genome Vaccine, Malaysian Vaccine and Pharmaceutical, they have this MOU for Pfizer vaccine. And MGVI also, Malaysian Genome Vaccine Institute, also one of the facilities that's supposed to become the pilot manufacturing for vaccine, pilot study. Next. Strategy 3, the clinical trial. We know that Institute Clinical Research and also CRM, very active in clinical trials. And we already have facilities to conduct the first in-human trial in Ampang and also in Hospital Umum Sarawak. Next. Strategy 4, human capital development. We have 4 of us actually, because in IMR we have 2 projects currently to develop the vaccine. First, the inactivated virus vaccine headed by Dr. Rozainani and Dr. Siti Nozawani from Infectious Disease Research Center. And for the mRNA-based vaccine for COVID-19, myself and Ching Yiming from Allergy Immunology Research Center, IMR. And 4 of us actually had the opportunity to train in Baylor College of Medicine in Houston, Texas, USA last year for vaccine development program. And we also have a opportunity to have a technical meeting on the studies in non-human primate test system at National Primate Research Center of Thailand, Chulalongkorn University in Thailand, with collaboration with USM and also NPRA, National Pharmacy Regulatory Authority. Because in Malaysia at the moment, we don't have facilities for non-human primate. We only have facilities for small animals. And during the National Biotechnology Symposium, there are many researchers actually update their vaccine research. This National Biotechnology Symposium conducted by NIBM. Next. Strategy 5, vaccine technology acquisition and development. As shown here, Pharmaniaga with Bionet Asia, and then Solution Group with CanSino, MVP, and also we have some sort of meeting in USA with the Greenlight Bioscience to check about their technology acquisition in mRNA vaccine. Next. And lastly, for the strategy 6, vaccine communication, this is very important so that our community or public can know about our vaccine development. These are the examples of what activities that we've done during the vaccine communication in Majalah 3 and TV and so on. Next. So way forward, there is an opportunity to establish a new paradigm for vaccine development and access that builds of new practices, strengthen Malaysia preparedness by investing in vaccine technologies, regional research and development and manufacturing hub. For that, I end my presentation. Thank you.
Thank you so much, Dr. Masita. Very well presented, as well as keeping your time. We move on to the next presenter. We have Dr. Rozainani Mohammed Zain, who is the consultant clinical virologist and currently head of virology at the Virology Unit, IDRC. She supervises all specialized viral diagnostic testing or activities that are carried out in the unit to support the laboratory testing for most government hospitals as well as private primary care facilities. And in line with Ministry of Health strategic priorities, Dr. Rozainani has taken up the challenge to lead an important project in developing and implementing HIV drug-resistant genotyping assay for the country. And she's also one of the PI, together with Dr. Zawani, for the development of inactivated COVID-19 vaccine. And I know there's a team in virology that are looking into development of POCT.
First of all, I would like to thank the organizer for the invitation to speak in this NIH conference. And the topic that was given to me is on the quick updates on the development of point-of-care testing for rapid diagnosis. Next, please. Yeah. This is the presentation overview. Just a quick one on the introduction, what point-of-care testing is all about. And then we move on to the examples of rapid diagnostic kits or rapid test kits, used in the clinical settings. And also, we're going to look at on the status, the current status on the RDT development here in IMR, and also the way forward. Next. So it's always good to start off with the definition, So we know that point-of-care testing is a rapidly expanding area of the laboratory medicine nowadays. So point-of-care is basically, I think everybody knows what point-of-care is all about. It is a near patient testing, normally performed near to the patient or the bedside of the patient. And the result from the test can be used to further improve or change the care of the patient. So there are many advantages and also disadvantages when it comes to point-of-care testing. So this slide is showing some of the evolution of COVID-19 testing in Malaysia. I think everybody knows this as well. We first started early of the pandemic with PCR. I think at that time everybody was talking about PCR, and then some were talking about city value. So there's a lot of guidelines also were published at that time. But later on, during the pandemic, there are other tests also available for the diagnosis of acute COVID-19, which were to include professional use of RTK, COVID antigen, and then later on, we move on to self-test. And then in terms of the sample also, we first used the nasopharyngeal swab, and then later on, we moved to the nasal swab as well as saliva. So as you can see here, the movement or the evolution is clearly illustrated that the usefulness of rapid test kit in the public. Next, please. So if you look at our data, COVID-19 data, this is Malaysian data from KKM now. I would like for you to look at the test conducted. So as of on the 2nd July 2023, as you can see there, about 98% of the tests reported were from RTK, and only I think about 2% were based on PCR tests. So indeed, RTK play a main roles now in diagnosis COVID-19. Next, please. So what are other examples of RDT use in Malaysia at the moment? So one of it is, I think the availability of rapid test kit to detect the presence of HCV antibodies. So these are, the test is available in most of the KKs in Malaysia. So this is in line with what WHO has documented in one of the guidelines. Next, please. So this is just to show that anti-HCV antibody can be detected either using a single rapid diagnostic test, or it can be also used laboratory-based immunoassay. Next, please. So again, to further stress the importance of having a rapid diagnostic tests in the public community, we had conducted a study on assessing the implementation of this decentralization HCV testing at primary healthcare facilities in Malaysia, the Head Start project in Malaysia. This is together with Fine Study. So this in this study, we used ST BioLine, which is a rapid diagnostic kit. You can move on to the next slide. Thank you. So this is WHO pre-qualified in vitro diagnostic that was listed way back in 2016. And again, this is a lateral flow kit and a qualitative detection of antibody specific to hepatitis C. And again, if you look at on the slide, it does have a good sensitivity, 98% and 100% specificity, which is similar to ELISA test. Next, please. So again, this is another example how RDT is used in Malaysia. As our first line to detect the presence of HIV antibody, we also use a rapid diagnostic test kit at the KK level. This is the first screen to detect HIV antibodies among adults at KK level. And then usually we use a kit with high sensitivity and specificity. Usually we go for 100% sensitivity and 100% specificity. Of course, this is just a screening. We need to send blood for further confirmation of HIV. Next, please. So I would like to draw your attention to this one, Jom test. I think many of us might have known this. So this is HIV self-testing study. So this is basically a pilot study presented by the Charia, UMMC, and Thailand Love Foundation. This is basically to cater the needs from the community. And the aim is basically to pilot and evaluate an integrated model for HIV self-testing targeted the key populations in both countries. Next, please. So for JOM tests, they have listed two self-tests, RDT self-test. The first one is HIV self-test. This is based on finger prick, yeah. And the other one is Aura Quick, which is an oral swab. So, which again show that the use of RDT is important in the community. Can I have, yeah. And then last week, I think MOH has released the guideline on the implementation of HIV self-tests. This is basically to prepare extra alternative to the targeted population for them to go and test themselves for HIV. And then from this HIV self-test, we can link them to care. Can I have next, please? So again, this is some of the characteristic of rapid test kit that has been published by WHO way back in 2000, yeah? The first, this is, we call it WHO assured criteria. So the first one, it has to be affordable. So the test has to be cheap so that many can afford to use it. It has to be really sensitive and specific. You don't want to have a test with false negative, yeah. But probably you can accept tests with a low level of false positive. And then it has to be user friendly. If it's too difficult to do the test, it's not possible for the public to use it. And then it has to be robust and rapid. Usually when it comes to the point of care or rapid test kit, the test usually can be completed within 15 minutes to 20 minutes, yeah? And then it has to be robust in terms of it's stable, it can be kept at room temperature, and then it can last for quite some time. It can be up to 12 months. And then the other characteristic is that it can be equipment free, and also it should be deliverable, yeah? So again, it was adjusted now to reassured. So they added two more items, R and E. R mean is a real-time connectivity, which means that rapid test kit can be connected to any simple mobile unit, so that you can get rapid results. And E is to collect the samples, which means that it's either just a finger prick or you can use saliva to test. Next, please. So again, these are some of the advantages of using RTK or RDT. I have mentioned most of it, but I would like to draw attention that sometimes rapid test kit, the results can be improved by having a reader, but in many cases, we can just read the result by using our naked eyes, yeah? And then again, it's important also to note that currently we do have a lot RTK, which is multiplex, which means that you can detect more than one disease at one time. So if I can have my next slide, please. So before I move on to the status of the kit evaluation and IMR, this is a simple statistics just to show you that we have been doing kit evaluation at the virology unit IMR. We used to have only for HIV, dengue, hepatitis, which is hepatitis B and C. But if you look at on the slides, there was an increased number of kits evaluated since 2020 because of COVID. Yeah, so we had evaluated COVID-19 PCR kits, as well as antibody kits, and as well as antigen kits. Yeah, so I think because of the pandemic, it really showed us that the use of RTK is important in diagnosing some of the diseases. Next, please. Yeah, so we move on to the current status on the rapid test kit development at IMR. So we had the opportunity to undergo a training at the Aris Biomedical. It was a 5-day training. The lab is basically situated in Allentown, Pennsylvania. This is basically, Aris Biomedical is a leading manufacturer and supplier of rapid diagnostic reagent, components, and related equipment for membrane-based assays. And they also provide some of the services which to include technical assistance, custom conjugations, antibody purification, and assay development. So I'm going to show a quick video on the actual training. The video was prepared by one of our staff at virology unit. Yeah, if you can click on the link, that would be good. Thank you. Yeah, just click on the link, the lateral flow video. Just bear with me for a second. Is it going to happen or is it not? Yeah. Yeah. I think I just proceed. If we have the video ready later on, we can always play it later. Then can I have my next slide? Oh, it's coming. Thank you. I think we need the sound as well. Thank you. Maybe we can go back to the slide. Next, please. Okay, what we are proposing now is to use these two laboratory. One is an MR processing lab, and the other one is Semiotrop Med Store as our dry room facility. We are still in the process of getting approval from the owner of the labs, but we are hoping to get it really soon. In fact, we are preparing the rooms for the KEEP development, and it's going to be a shared facility. So we welcome any collaboration from any units or centers or any institutes for this purpose. Next, please. So, so far we have managed to purchase some of the equipment, for the kit development. Actually, we are using our account amanah money to purchase all these because these are really crucial equipment for us to proceed with the kit development. We need to have balance. We need to have desiccated cabinet, tabletop continuous band sealer, incubator, hygrometer, pH meter, as well as strip cutter. So these equipment have been purchased and it has been located in one of the labs I showed you just now. And the next slide, please. And these are some of other equipments that we are going to purchase. We are waiting for the arrival of these equipment. And as you can see, isoflow reagent dispenser is really important for us to have it here in IMR. Yeah. So in conclusion, we have started our kit development project. I have given some of the updates on the status of the kit development. Again, we need to have further discussion with various stakeholders for the development, evaluation, marketing on the kit. In fact, I think now there's one company has shown their interest to support if we were to develop a dengue kit. Yeah, and then not yet. Okay, they asked me to end. Okay, and then as I mentioned, we need to continue procure some of the equipment that we might need for the kit development. And again, I think PPP is really important. So we have to get some support from not just from our top bosses, but also from the private, so that this project can be sustained in the future. Thank you.
Thank you, Dr. Nani. Very interesting talk, especially on the flow of the POCT in IMR. With that, we move on to the last speaker, Dr. Muhammad Rizwan Muhammad Abdul Raza is a research officer and the head of bioassay unit in a Herbal Medicine Research Center, IMR. He obtained his PhD in Structural and Molecular Biology, University College London, UK in 2012. He has experience in conducting many researches involving herbal medicine, in drug discovery for malaria, dengue, COVID disease. Currently is actively involved in biomedical research focusing on preclinical drug discovery or antiviral against dengue, which is important with DNDi initiative, and as well as SARS-CoV-2 in collaboration with other research institutes. With that, I would like to put my hands together, everyone put together to welcome Dr. Muhammad Rizwan on this talk, anti-SARS-CoV-2 and anti-inflammatory activities of Maranthos, Pumilum aqueous ethanolic standardized extract. Over to you.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. Thank you for your kind introduction, Dr. Ravi. Okay, so this title I'm going to present our experience during the COVID-19 pandemic in 2020. Okay, this project is actually a collaboration with Medica Natura under the Researcher Industry Scientific Exchange Program conducted by MOSTI. Okay. Next slide, please. Okay. So I think I'm not going to actually mention in detail about the status of
COVID-19 because it's already mentioned by our speakers just now. So during the COVID-19 pandemic in year 2020, so a lot of effort have been put forward to study the effective vaccine and treatment for COVID-19. So there are three focus in searching in COVID-19 treatments. One is finding a new drug, and then I think you are familiar with this drug, such as Paxlovid and Molnupiravir. And second is performing a drug repurposing. Okay, as you still remember about remdesivir, chloroquine, and ivermectin. And of course, last is about the herbal medicine products developments. Yeah. Okay, a lot of herbal medicine products have been put forward as potential candidates for COVID-19 treatment, which includes herbal products from Thailand, China, and also Malaysia. So we in Herbal Medicine Research Center, IMR, are also involved in the race of herbal drug discovery for COVID-19 potential treatments. As a record, HMRC IMR has screened more than 100 plant extracts and compounds, including 4 important herbal products such as Kacip Fatimah, Tongkat Ali, Empu Bumi, and Misa Kucing. Next slide, please. So this is a slide about the potential target of COVID-19 therapy. So the severity of COVID-19 is caused by hyperviremic condition, which could lead to overproduction of cytokine that cause hyperinflammation. The uncontrolled hyperinflammation will lead to severe COVID-19 symptoms such as acute respiratory distress syndromes and multiple organ failures. So most of COVID-19 drug discovery studies are focusing on targeting the markers of viral components, as shown here, that are essential for viral replication such as S protein, human ACE2 receptors, protease enzyme, MPRO, and also the RNA-dependent RNA polymerase, which actually very essential in a viral replication process and also viral entry into the host. Now, another way of actually combating the COVID-19 severity is by targeting the components which is essential and in pro-inflammatory process, such as the toll-like receptors, Chinese kinase, and also focusing on pro-inflammatory cytokines productions. Next slide, please. So these are examples of medicinal plants from Thailand, okay, that are previously reported for their anti-SARS-CoV-2 activities. Okay, in the clinical studies conducted by Thailand, both plants, Andrographis paniculata and its active compound androcarphlite, and Bosenbergia rotunda, as well as its active compound spanrotin A, exhibited the SARS-CoV-2, inhibited the SARS-CoV-2 replications and pro-inflammatory mediators as shown in the table here. So these plants products have been put forward for clinical trials and currently in the phase 3 clinical trials in Thailand. So what about Malaysia? Next slide, please. So in Malaysia, we have found that Marontidas pumilum, which also a synonym as Labicia pumila, is also one out of 4 Malaysian herbal products that is actually studied in detail for its COVID-19 potential. So in Malaysia, this plant was locally known as Kacip Fatimah and traditionally used for induction of and facilitation of labor, treatment of flatulence, dysentery, dysmenorrhea, gonorrhea, and sickness in the bones. So all these traditional claims are supported by scientific studies, especially the studies focusing on postmenopausal syndrome, polycystic ovary syndrome, PCOS, osteoporosis, antibacteria, anti-cancer, anti-diabetic, and latest scientific evidence was on weight management in obese individual, which is also a clinical study published this year in 2023. So that is the SK7, the test items that I'm going to mention just now. Okay, next slide, please. So the SK7 is one of the plants that we have choose. Okay, one of the main justification for further study of this product is because the phytochemical compounds which was identified by the SAMS. Okay, as we can see in the graph here, we can see that several important compounds that have been previously highlighted and associated with anti-SARS-CoV-2 studies, such as galic acid and the derivative, for example, galactocatechins, epigalactocatechin, and also epigalactocatechin galate. Okay, next slide, please. So that's why the objective of the study is actually to investigate in vitro anti-SARS-CoV-2 and immunomodulatry potentials of the monitorized formula standardized extract product, or also we know as SK7. Okay, this study actually focusing on the anti-SARS-CoV-2 activity against the wild type and Omicron SARS-CoV-2 variants. Second is about the potential mechanism of actions, okay, which I'm going to mention in detail on the next slides. And the last is about the potential anti-inflammatory activity, which is specifically against the toll-like receptor 2 and toll-like receptor 4 responses. Okay, next slide, please. So this is actually the workflow for anti-SARS-CoV-2 testing. For antiviral and screening activity, the Vero-E6 cells, which is the host for the SARS-CoV-2, were exposed with different range of SK7's concentrations together with the SARS-CoV-2 virus. So the incubation was at 37 degrees and 72 hours. Actually was to permit the infection process in Vero cells, which lead to the cytopathic effects representing the viral infection condition as showed in the figures there. So there's a difference in the cells that are actually infected with SARS-CoV-2, where it shows CPE effect or cytopathic effect, and we can see the clear difference between the healthy cells. Okay, in terms of the morphology of the cells and the density of the cells. Okay. So the inhibition of the SK7 against the viral-induced CPE was measured by the ATP-based assay on micropipette reader. Okay. And we also measured the effect of SK7 on the cell viability as well in parallel. And the endpoint data, which is half maximum effective and cytotoxic concentrations, was determined by dose response curve analysis. Okay. The selectivity index was determined to give an idea on a relative effectiveness of antiviral property of the extracts compared to exhibiting cell death. Next slide, please. So these are the results from the test. So it shows that the result shows that the SK7 actually reduced the infection of wild type and Omicron SARS-CoV-2 in Vero cells with the EC50 about 22 and 60 microgram per ml respectively. And it also showed that the cytotoxic concentrations of the extract was actually 5 times higher than the effective concentrations or than the antiviral concentrations. So as you can see here, if we calculate this selectivity index, the selectivity index is actually about more than 5. However, it's less than 10, which corresponds to the moderate antiviral activity of this test item. Next slide, please. Okay, the actual anti-SARS-CoV activity of SK7 was also actually tested on human lung cell as well, to actually mimic the actual condition in human with COVID-19. So this is the workflow. It's actually similar with the previous workflow study on the Vero cells, except that the cell was replaced with the human lung cell, which is genetically modified to highly express the human ACE2 and the other receptors. And the result was analyzed by real-time PCR to quantitate the virus nucleoprotein because of the SARS-CoV-2 virus actually is not actually producing CPE effect in these cells. So that slides, please. Here clearly shows that instead of Vero E6 cells, the SK7 anti-SARS-CoV activity was actually more potent in human lung cells. So we can see here the value of the EC50 is actually lower. Okay, when we calculate the selectivity index, it actually produce the value of more than 10. So you can see that the activity of antiviral towards SARS-CoV-2 is selective enough for us to actually proceed with the futures for the future studies. Okay. Next slides, please. So then we further our study to determine the potential mechanism of anti-SARS-CoV-2 activity. So for this study, we actually perform a target-based assay. Okay, in this experiment, we concentrate on targets on actually two possible routes. One is through the S2 SE2 interaction, and second is through the targeting the T3L proteases. Okay, the test was performed by using the enzyme assay kits that we purchased. Okay, which is called a SE2 SARS-CoV-2 spike assay kit, and also the other kit is called 3CL assay kit. Okay. In this test, we test we test three concentration of the SK7. Okay, 5, 10, and 20 micrograms, and the rest is a control for the study. Okay, next slide, please. So from the results, the SK7 showed actually minor inhibition against the ACE2S1 interactions. So the figure A there shows that there is some inhibition, but it's very low. And then, however, the extract shows prominent inhibitions towards the 3CL protease activity. You can see that there's the 3CL protease activity actually decreased to 40% at 20 microgram per ml. Okay, so it shows that this SK7 actually inhibit the 3CL protease activity, which is very important in viral applications inside the cells. So, next slide, please. So other than antivirals, so the potential of anti-inflammatory property of the SK7 was also tested. For specific anti-inflammatory assays, the toll-like receptors such as TLR4 and TLR2 were chosen because these receptors have been previously implicated in cytokine storm induced by SARS-CoV-2 infections. So both TLR's activations were associated with the binding of SARS-CoV-2 envelope and S proteins, which leads to the production of pro-inflammatory cytokines. So the principle behind this assay is whether or not the SK7 could inhibit the LPS-induced TLR's activations on the human embryo kidney cells expressing the human toll-like receptors. Okay. So apart from this assay, the effect of SK7s on the human embryonic kidney cells, cell viability was also conducted. Yeah, this is to actually eliminate the false positive activity, which could cause the abstract cytotoxicity. Okay. Next slide, please. So there are two figures here. The results for the activity of TLR2 and TLR4. Based on the result, it clearly showed that SK7 prominently inhibit the TLR4 signaling activities. Yeah? Okay, next slide, please. So I will simplify this discussion part. Okay, the anti-SARS-CoV-2 activity of the SK7 could be due to its activity in affecting the 3CL protease activity. So the SK7 extract contains numerous compounds which have previously studied for anti-SARS-CoV-2 activity in silico and or in vitro. These compounds are catechins derivative and gallic acids. So one of the compounds, for example, is EGCG, which is also a catechin's derivative, could be an active compound of the extract, as anti-psychoactive activity of this compound have been demonstrated in vitro and in silico studies. The potential of SK7 in inhibiting the toll-like receptor response is interesting, as this signaling pathway is actually one of the pro-inflammatory pathways that could cause the COVID-19 pathogenesis. Next slide, please. Okay. So our data, in conclusion, our data showed that the extract could actually reduce the infections in vitro by inhibiting the G3L protease activity. Second, the SK7 also showed potential anti-inflammatory activity by reducing the TLR4 signaling pathway. And last but not least, in order for us to actually see whether these findings are translatable or not, okay, for the study in COVID-19 animal models, such as hamsters or SE2 transgenic mice is warranted. Okay. Next, I think that's all. Thank you for your attention.
Thank you, Dr. Rizwan. A very good presentation, and I hope that your findings will be published soon. So if that comes to the Q&A session, we have about 5 minutes only due to constraint of time. I will allow about 3 questions maybe. Can you come forward to the microphone, introduce yourself, and then name the speaker that you would like to ask? Thank you.
Assalamualaikum. My name is Dr. Ilham from Program Perkhidmatan Farmasi. My question to Dr. Masita. I have 2 questions. First question, do you mind to share with us the list of prioritized vaccine available from the NVDR? And secondly, post 2 years after the NVDR launching, to what extent has we ensured our vaccine security to the public? Thank you.
Thank you, Ms. Naili. Kau Dr. Naili. Thank you for the question. So for the first question, the list of vaccine that we prioritize in our NVDR, that's why in my presentation, my presentation quite fast, I know. There is a committee actually now looking to really identify what vaccine that we want to prioritize. Before this, we have the list, but that list in NVDR, because the program, the NVDR analysis based on the data in 2019, if I'm not mistaken, but now it's 2023. That's why we have this committee that will look into the data again, but the current data. And this analysis will be led by a team from our Institute of Health System Research, Dr. Zam here. So they will do the analysis. So after we have the analysis, then we can really know the current vaccine that need to be developed. Yeah. Of course, there are many prioritized before this, either in the childhood immunization program or in the new vaccine that we not yet available in Malaysia. But again, we need that analysis to really scrutinize and strategize what is the priority. So second question about NVDR already launched 2 years, right? But to be honest, the launch, if you notice, in November 2021, but all the allocation and everything to set up the governance actually started last year, mid of last year. So the question apa tu? Vaccine security. Okay, still in terms of the vaccine security, I think the one that for vaccine COVID-19, we just continue as the contract. That one different. And then for the vaccine security, I think we still not yet really finalized in terms of the vaccine security. Still in the discussion. Because our committee is not really meeting regularly. Even this year, the MVSWG still not have the meeting yet. We only have the Vaccine Collaboration Network meeting. So to answer about the vaccine security, I think it's not really because it involves the industry. For example, for us in research institute, we are more to the R&D, but for the industry, they have, remember just now I've shared about the few companies already have signed the MOU in terms of their plan to have the vaccine production in Malaysia. So our target in MBDR, actually, we want to have like Malaysia can produce vaccine either by collaboration with the other established pharmaceutical, or we have our own vaccine product. So this is involve many players, the private sector and the government. And for the R&D, mostly by Mosti look over all this R&D. Even for the vaccine security part of it also by Mosti also. So I hope I answer your question, because this is still, if you notice, although we launched in 2021, this is like 2023, only 2 years. We cannot really say much about the vaccine security. Thank you for the question.
Thank you, Dr. Masita. Are there any more questions from the floor? If not, can I ask a question to Dr. Nani? Dr. Nani, if you're given a choice, what would be your topmost choice for designing a POCT for infectious disease currently?
Dr. Ravi, for the question. Yes, I think the topmost priority for us is now is dengue. We know that dengue is always top on the prioritized disease list in Malaysia. So we think that it would be good to develop the dengue kit first. But of course, we do have a lot of challenges when it comes to the dengue. But I think with a good collaboration with the hospitals, where we later on might need to do the kit evaluation at their side, I think it can be done. In fact, as I mentioned during this presentation, also there's one company already showed their interest to support if we were to go for a dengue kit. Because I think if you look at the current RDT for dengue, in terms of the performance, it varies. So I think we really need to have a really good kit for dengue so that it can be diagnosed fast and that it can be treated fast as well. So I think that would be our top on our list, and the rest, it will come based on the needs from the clinical side as well. Thank you.
Thank you, Dr. Nani. Just one more like question for Dr. Rizwan. I mean, in vivo testing is something very important for safety as well as efficacy. I know a lot of people use animal. What is your take on using zebrafish to replace mice and all?
Yeah, in terms of the models, so far there's only mouse model that's been developed for the SARS-CoV-2 infections, but for zebrafish there's none. Okay, I think this is due to the complexity of the organism itself, because zebrafish might not 100% actually mimic the infections in humans. But in mouse models, it's different, because there's most of the symptom development after the infection is almost similar to humans.
All right. Thank you so much. If there are no more further questions, can we put together our hands to thank all the three speakers for the excellent talk? And with that, I hand over to the Master of Ceremony. Thank you.
Thank you, Dr. Ravindran, and our experts from IMR for a very informative, insightful session. So as a gesture of appreciation, we would like to invite Dr. Muhammad Farunizal Matno to come to the stage to present the mementos to our moderator and speakers. We would like to invite Dr. Masita Arif, Dr. Rozainadi Muhammad Zain, Dr. Muhammad Rizwan Muhammad Abdul Razak, and last but not least, Dr. Ravindran Thayan Sukumaran. Thank you very much, Dr. Muhammad Farunizal and all our experts from IMR. Distinguished guests, ladies and gentlemen, we will now proceed with Symposium 2 with the theme Economics, Health and People. Our moderator for this session is Dr. Nur Amalina binti Zaimi, Dental Officer from Institute for Health Systems Research, IHSR. The speakers are Dr. Norzam Azihan Muhammad Hassan, Head of Center for Health Economics Research, Institute for Health Systems Research, IHSR, and Mr. Sivaraj Raman, Senior Pharmacist, Institute for Health Systems Research, IHSR. Please welcome our moderator and speaker on stage.
Hello. Assalamualaikum and a very good afternoon, ladies and gentlemen. Welcome to Symposium 2 titled Economics, Health and People. I am Dr. Nur Amalina Zaimi from the Center of Health Economics Research, IHSR, and I will be serving as your moderator for this symposium. Within this symposium, we will delve into two essential topics, focusing on the significance of health economics in the decision-making process. Health and economics are closely intertwined. The state of a population's health can have significant effects on a country's economy, and economic factors can influence people's access to healthcare. A healthy workforce is more productive and can contribute to economic growth. On the other hand, healthcare costs can impact individuals' financial stability and overall economic well-being. Therefore, this is closely related to our symposium today. Before proceeding any further, allow me to introduce our first speaker. Seated to my far left is Dr. Norzam Azihan Muhammad Hassan, a distinguished public health physician and currently is the head of the Center of Health Economics Research at the Institute for Health System Research, Ministry of Health, Malaysia. Dr. Norzam has extensive experience in conducting research related to health economics. He has established collaborations with numerous stakeholders, both locally and internationally. His expertise shines through his published works on economic evaluations, econometrics, equity, and efficiency analysis showcased in high-impact journals. Additionally, Dr. Norzam is also recognized for his active engagement in delivering capacity building and offering technical consultations on health economics to stakeholders at multiple levels within the Ministry of Health Malaysia. Therefore, I am honored to welcome Dr. Norzam Azihan, who will be delivering a captivating presentation titled Turning Health Economics on its Head. Dr. Norzam, the floor is yours.
Thank you, Dr. Amalina. Very good morning, good afternoon, everyone. So before I start my presentation today, I would like to head up the session first with a quick questions. My quick question will be, if you have to choose between health and also wealth, which one do you choose? Please raise your hand for those who choose health. Raise your hand. So I assume those who don't raise their hand choose wealth, okay? So actually it's very irony, isn't it? If you have to choose either one, either health or wealth. So hopefully by today's presentation, we're going to go through and explore the health and also the economics and also those terms which are actually quite, we can see very distinct from each other, but then it is very interconnected and interrelated with one another, which actually is very difficult for us to separate between health and also the economics. Okay, hopefully after going through this speech today, when we know how to relate the health and also the economics, we'll be able to make better decision and for the better health of the populations. Okay. Next. So this is the content of my presentation today. Okay, next. So basically health and wealth. So everyone knows about health. This morning, even our DDG also have mentioned the definition of health is a state of complete physical, mental and social well-being and not merely the absence of disease or infirmity. Meanings, you want to achieve the complete physical and mental and also social well-being. Whereas health or wealth is the value of asset worth owned by a person, community and company or a country. Meaning anything that is value to you. So in the end of the day, if let's say you value your health, meaning that health is actually a part of wealth. It's a form of wealth as well. So if let's say you have a good health, you can work, you can produce, you can receive incomes, you can have a productive life, and also you can contribute to the economy. So looking at the perspective of individual or a country, this is very much relevant. And also with this good health, it can prosper the countries and also the people as well, rather than just concentrate on prospering the countries alone without improving the health of the people. So the poor, the second is the economic impact of poor health. So we know that poor health and has an economic repercussion. If let's say you have a poor health, you have higher healthcare costs, decreased productivity and increased absenteeism. And at the end of the day, it will cause constraint to individual and also the economy. If let's say we continue this, this will be a cycle of poverty and also poor health. If let's say, for example, we look into the perspective of individual. If let's say you are sick, you have to seek for treatment and then you have to fork out your own money to seek treatment. And then you also cannot go to work, you reduce your productivity and also you have to absent from your work. At the end of the day, it will consume some of your resources, your incomes and your salaries. And at the end of the day, if let's say you cannot work, you don't have any income, then your health is still poor, you will go into the cycle where you, at the end of the day, you cannot even assess the health. And at the end of the day, the cycle will continue. Okay. While poverty also, we know can cause perpetuous or ill health, as I mentioned before. The economic growth also has its own effect on multitude of potential health hazard. For example, if let's say you economy grow, probably you will have higher incidence of higher chances of getting incidents, for example, your environmental issues and so on. So that's kind of health or hazard, also potential if let's say your economy also grow. Next. So we can also treat health as an investment rather than just an expense. Usually in Ministry of Health, in governments, we thought that we pump a lot of money into health, but we never receive any outcome or any benefit. But actually, health is just an investment where when you invest to the people, people get healthy and people can work and to produce more for the countries. The benefit of health has been shown to yield a returns in the form of healthier and also more productive individuals. Not only health, education and preventive measures also results in healthier and also more productive individuals. And at the end, the health can increase the labor supply and also the productivity for the countries. It can contribute to the major economic growth. And if let's say you have early childhood nutrition, it can also lead to improved cognitive ability and also future economic success. In the end, the health should not be viewed as investment rather than the expense of also the cost saving on other factors such as sectors, not simply as drain of the economy. Okay. Next. And then we also know that incentive can drive behavior. So whatever incentive we're giving, we're able to reduce or to change the behavior regarding health. For example, the financial incentive promote desirable health behavior and also discourage unhealthy behavior. For example, here, the one I mentioned here is the lower insurance premium for healthy habit can motivate individuals to make healthier choices. And other example would be such as studies done by University UKM that they give incentive for reducing weight. So they're able to reduce the weight by giving incentive. So there are lots of incentive that we can use to drive the behavior, or there's a lot of methods we can use to change the behavior. One of it is through giving some incentive. Okay, others are next. And then in health economic, the social factors also matters. We often heard about the social determinant of health, such as the economic stability, education, health and healthcare, neighborhood and built environment, social and community context. All of these social determinants of health can improve the health and also the health outcome. And it will result in reduced healthcare costs. Okay, next. So in healthcare, we also often do cost effectiveness analysis to decide which intervention we want to implement. However, there's a case where we call it a paradox of cost effectiveness analysis, where the intervention is cost effective. However, there is an ethical concern and public perception that we have to weigh. And probably the intervention may not be as easy to implement as what we thought. For example, here given is the vaccination program, also vaccine hesitancy. We can see that sometimes we can see from our result that the vaccine program is cost effective. However, there's a hesitancy from the public, so it's very difficult to implement the program. And other paradox we can include such as political consideration. What the political consideration for the government? Sometimes we always change the government, so they have their own agendas. And behavioral factors, such as I mentioned, the vaccine hesitancy. Budget constraint is also one of the example. For example, you know that the vaccine, the hepatitis C is very cost effective. However, the drugs for hepatitis C itself is very expensive, and we don't have enough budget to provide the drugs. And the other one is the high upfront cost and also the long-term saving. Sometimes in implementing intervention, you have to fork out a lot of money for the upfront costs. However, sometimes we forget about the long-term saving that we can receive. Okay. Then it's about health inequality and economic disparity. Health disparities and health disparities always reflect the economic inequalities. For example, if let's say a country have very huge gap of poor and also the rich, you can see that the health disparity is also there. Some of them, they are very not in a good health. Some of them who are in very high or high end of the group will have a better healthcare access. So example of this is the marginalized communities. For example, the poor, sometimes in Sabah and Sarawak, they have all these immigrants. So they have less access to healthcare, nutritious food, and also safe environment, and they have the higher risk for health. Next. To develop a policy for healthier economy is a policy maker role to integrate health and also economics. So investment in health, for example, the infrastructure, disease prevention, and also the education can result in better outcome and also the economic growth to the countries. So they have to weigh to take into account both health and also economic for them to have a healthier economic. When I say a healthier economic here, it's not only improve in GDP per capita, reduce the employment rate and so on. It's about how the economy able to support the health of the population as well. Next. And at the end of the day, what we want is to have a holistic approach to our healthcare systems and also to the country as a whole. But this one will require a synergy between health and also the economics. The healthcare experts, economists, and policy makers need to collaborate to provide a comprehensive solution for the health. and a collective effort also is necessary to have a more sustainable, equitable, and also prosperous society. Next. So the conclusion. So in the end of the day, since the first time I come here, I asked about health and also wealth. In the end of the day, health and economics, they are all very interconnected. It's very difficult for you to separate both of them. By changing our perspective, we can find innovative way to improve our health outcome and economic prosperity, and also health and economic should go hand in hand for the betterment for all. Next. So these are my references. And thank you. This is my context. If let's say I did any questions, thank you. I pass it to our moderator, Dr. Malina.
Thank you, Dr. Nurzam. We are greatly appreciate your highly informative presentation. It was truly enlightening and has provided us with ample food for thought. I believe that the integration of health and economics is crucial for decision-making and ensuring fair and equal access to high-quality healthcare services for all members of the society. Next on the agenda, we have Mr. Sivaraj Raman. Mr. Sivaraj is our second speaker for the day. He is a skilled pharmacist, also serves as a researcher at the Center of Health Economics Research, Institute for Health System Research, Ministry of Health, Malaysia. Previously, Mr. Sivaraj held various roles within the pharmacy department of Hospital Keningau. His specialization lies in health economics and pharmacoeconomics, focusing on cost-effectiveness analysis, costing, and budget impact analysis. Moreover, he has conducted extensive research on pharmacy practice, therapeutic drug monitoring, and pharmacovigilance. Without any delay, let us warmly welcome Mr. Sivaraj Raman as he presents his insightful talk titled The True and Hidden Cost of Cancer Patients' Perspective.
Testing, 1, 2, 3. Okay, thank you, Dr. Amalina. A very good afternoon, ladies and gentlemen. I'm Sivaraj Raman, and I'll be sharing today a bit on the true and hidden cause of cancer. And we will be talking today from the lens of the patients. Next. So for today's presentation, I'll be sharing 3 things. Number 1, we'll be looking into what is the economic burden of cancer. Number 2, we will look into why should we adopt a patient perspective, especially when we are looking into economic burden of disease. And lastly, I'll give you 2 case scenarios of Malaysia on how, when we use patient's perspective in cost analysis, it will be helpful for decision makers. Next. Okay, so let's start with why cancer. Well, it is very clearly established that cancer has a very high disease burden in Malaysia. Following the Global Cancer Observatory data, it is estimated by the year 2040, the incidences of cancer in Malaysia is going to double to 87,000. And what is worse is that in addition to high mortality, most of the incidences of cancer in Malaysia is detected at later stages. Exception to breast cancer, all other cancers are mostly detected at stage 3 and stage 4, which means the burden, the disease burden of these cancers are also higher compared to other diseases. Next. So when we talk about disease burden itself, quite often we use clinical terms. We look into disease burden from the perspective of mortality, morbidity, and also disability. But over the period of time, looking at disease burden from an economic point of view has gained traction, especially to certain benefits of using economic values for planning and decision making. Okay, we will be talking about that later on. But I would also like to draw your attention to the 3 other factors which are often neglected, and hopefully you as fellow researchers can look into the other 3 areas as well. So these are the psychosocial impact of cancer on its patient. What is the strain of cancer on the healthcare services itself? And lastly, the burden in terms of the caregiver and also the society around them. So there's a food for the thought, but we'll focus on the economic burden now. Next. So when we talk about economic burden, one of the way we do this analysis is also called cause of illness approach. So when we talk about cause of illness, what we are using is that we are valuing the resources that are consumed or foregone due to the presence of disease. When we talk about economic burden, we adopt a very comprehensive approach to the costing. So this consists of three areas: a direct cost, an indirect cost, and also the intangible cost. When you talk about direct cost, then it encompasses expenditures from the healthcare provider, for example, MOH, to treat and care for the patient. It also encompasses expenditure by the patient for their treatment and also to access their treatment, for example, for their travel and transport. Indirect costs, on the other hand, are costs or values that have been foregone due to the disease. And this is often measured in terms of loss of productivity. So we do have loss of productivity due to absenteeism from work, and it can also be loss of productivity due to premature death. Lastly is in the terms of intangible cost, which is pain and suffering to the patient. While this is quite important, most of the economic evaluations or economic burdens does not consist this third aspect, as it's difficult to be valued. Next. Okay, so from there we come about why is cause of illness or economic burden important? Well, in short, the numbers provided it's translated into dollar term, and this is the language for policymakers and also our politicians. What it means is that when you have an economic burden of a disease, it helps for you to identify what is the magnitude of the disease in terms of cents and ringgit. It also helps to justify an intervention programs that you're aiming to implement. And as fellow researchers, an economic burden of disease also helps you to guide or to request for allocations for researchers. I'm pretty sure that when you go for justifications, the first question that will be asked is return of investment. In order for you to answer the questions on return of investment is for you to know what is the economic burden of the disease being investigated. At the same time, it also helps in planning for policy, especially for preventive measures. And lastly, like what Dr. Zam have mentioned, is that sometimes when we want to measure cost effectiveness of an intervention or a preventive program, this cost data is also needed for us to make proper decisions. Next. Okay, so this is a very good way for us to contextualize the economic burden, and it's important. So we do have diseases, and with the diseases comes the direct and indirect expenditures. So some of the very early questions that our policymakers ask is that how much are we actually spending to provide this treatment or to manage the disease? And at the end of the day, we would like to have an interventions to resolve or to treat the disease. The next questions that they will ask you is that whether or not these interventions in place are cost effective. On the other hand, some of the questions that we have is that if the economic burden of this disease is very high, we then need to put in actions to prevent these diseases. So the questions that they would ask you is that, is this preventions or this investment in prevention worth it? And then in order for you to answer the questions, you also need to tell them how much budget do you actually need to provide now in order for us to save costs in the future. Next. Okay. So we were looking at economic burden, like what I said, from a very comprehensive aspect. We include the healthcare provider, we look into patient's perspective, direct and indirect costs. Well, I'd like to draw your attention now to a narrower perspective, specifically from the point of view of patient. Now, you may ask me, why do we then need to adopt a narrower perspective when we should look into it from a larger or broad lens? Well, the main reason is that currently in Malaysia, and especially in most of developing countries, the data on patient cost is lacking. So while we do have health expenditure studies conducted within MOH, we do have lack of data in terms of what is the expenditure of patients to access these cares. And the truth is that both patients and also clinicians are in the dark about the financial consequences of the disease. We are well adapted to know what happens when you get a disease, but we are not sure what happens financially when a person is diagnosed with certain diseases such as cancer. And this is very important because these factors is also one of the reasons which can become an access barrier to treatment. Okay, like what they say that to do no harm is our motto, it is also our ethical obligations to ensure that the diagnosis and treatment doesn't cause patients to end up becoming poor. And this is something that we need to understand both as a clinician and also as a researcher. And lastly, knowing this barrier, it is able for you to plan for your treatment interventions effectively and prevent wastage. Next. So you have a rough idea why economic burden is very important and how patient perspective, specifically in Malaysia, could be helpful in decision making. So what I will do is that the next few slides would be on 2 case studies, and I'll show you how certain questions using patient perspective, we can help and guide decision makers. So next. So 2 of the case studies that we'll be looking into. The first study is by Dr. Farhana and team. So this study is a large cross-sectional study, multi-center study involving 6 cancer centers throughout Malaysia. So what they're exploring is that they want to look into the financial burden of cancer, specifically for the B40 population. So the aim of the study to evaluate the benefit package provided under the PECA B40. So this consists of around 430 cancer patients all around Malaysia. The second study is my study, which was on cost effectiveness of mobile teledentistry for oral cancer screening. Well, for this discussion, we'll focus specifically on the patient expenditure. So these were conducted in 2 centers, HTA in Klang and also HUS in Sarawak. And we look into oral cancer patients, both during in their initial period and also their maintenance period. All right, so both studies adopted a patient interview study design. Okay, so let's look into the first question. Next. So what would the policymakers ask first? So the first question that they will ask you is that, how much does a patient pay? Okay, so from study by Farhana, Dr. Farhana and team, we identified that the total cost of cancer in the first year is around 13,000. And this is predominantly contributed by a loss of productivity. And then this is followed by non-medical expenditures and also medical expenditures. Both the non-medical and medical expenditures, we can also consider this as direct costs, and this can also be categorized as out-of-pocket expenditure by the patient, meaning this is the amount that they need to forego in order for them to access the treatment. Next. So when we look into the non-medical costs, we could see that for patients, this is predominantly contributed by 2 factors. Number 1, which is the transport cost, and number 2, which is the cost for their supplementation to buy vitamins, milk powders, and so on. On the other hand, next, when we look into medical costs, this is predominantly contributed by inpatient costs. So this is something it's worth to highlight is that this ratio and patterns would change according to different types of cancer. This study involves a mix of cancer patients, so you could see that the ratios are quite standard. Next. So the second question is, does patients spend more in public and private? I think that we can answer this question without even conducting the study. But what I would like to draw your attention is that this particular studies, the data collection is in public health facilities. So it is in tertiary healthcare facilities. What is interesting to see that even in B40 populations, there is still a group of patients who would access private healthcare for their treatment. Why? So that is something for us to explore. Things such as congestions, long waiting time would be one of the reasons why these patients, even though that they are financially constrained, they still access private care. And you could see that the populations that access both private and public healthcare, their expenditures is around 15 times greater than those who are solely reliant on public healthcare. Whereas on the non-medical expenditures is quite constant. That means that the behavior of patients accessing public or public and private, they are quite same. Next. Third question, does socio-demographic factors matter in patient expenditure? And I think that this study well illustrates that it does matter. So we could see that the patients in Semenanjung, Malaysia, on average, their per trip is around 90 kilometers and an annual cost of around 1,400 to access care for their cancer. When we contrast them to the other side of the world, where I was working before this, the distance travel is almost 3 times for these patients, and the mean annual cost is also almost double at around 2,200. So in terms of location itself and where these tertiary cancer facilities are located, there's already a great variation in terms of expenditure. Next. So you might ask, and what about other factors? Ethnicity, age, gender, your urban locations. Does it matter in how patients spend? Well, when we look specifically into oral cancer patients, we found out that 2 factors, socio-demographic factors, were significantly associated with catastrophic health expenditure. So, some learning point, catastrophic health expenditure is when your out-of-pocket expenditure for your medical and non-medical costs is more than 10% of your annual household income. So when we look into catastrophic health expenditure for oral cancer patients, we found out that patients from Indian ethnicity and those patients who are from the B40 populations were at a higher risk of having catastrophic health expenditure. So there are few hypotheses behind this. It can be due to the risk, it can be due to their lifestyle, but it can also be to their expenditures and their belief system throughout the disease process. Next. 4th question, does patients at different severity spend differently? Yes, the answer is yes. Also looking into oral cancer patients, you could see that patients at oral potentially malignant disorder, or you can consider them as pre-cancer stages, they spend around 1,200 annually in order for them to get screened and get their normal treatment. Whereas when they are at an early cancer, they spend around 3,000, and these numbers increase at later stages. What is interesting is that you can see that the margin of increase is largest for travel and transport. So even when you become, your cancer stage increases, the largest expenditure comes from the travel and transport. The treatment cost remains almost consistent because our treatment in public healthcare are highly subsidized. So we are able to protect the patients. Next. Okay, so last questions of the day. Does financial incentives help? So this I'll just draw to, there are a lot of financial incentives available for cancer patients, MACNA and so on. But what we will focus on is the PKB40 scheme. So PKB40 is an incentive where patients can get 1,000 ringgit if they have completed their cancer treatment. Okay. And then the patients are also given incentives for their travel. So okay, let's just give them some time.
Juga ada pameran peluang masuk ke politeknik untuk kursus-kursus profesional anak-anak anda. Datanglah ramai-ramai sekarang hingga jam 4 petang. Jangan lepaskan peluang untuk mendapat pengetahuan lanjut tentang penjagaan diabetes, buah pinggang, anak-anak istimewa dan pemeriksaan kesihatan oleh klinik kesihatan Kota Damansara.
Okay, I'm not going to wait for that. Okay, so when we look for transport, PKB40 also provide incentives for patients for them to claim for the transport to access their cancer treatment. So this is around 500 for those in Peninsula and up to 1,000 ringgit for Sabah and Sarawak. So some of you might wonder, it's unfair for those of us in Peninsula, why Sabah and Sarawak is getting more? Well, from the evidence, you can see that their travel expenditure is higher for Sabah and Sarawak. And the other question is that even though we are giving them money, this amount is not able to counter or pay for the total patient expenditure. It just covers around 18 to 35%. And these numbers might be different according to specific cancer. Next. Okay, so, and that comes to my take-home messages. So the first thing that I would like to highlight is that aside from looking at things from a clinical point of view, it is time for us to also look from an economic impact of a disease, because these numbers can also be substantial. Number two, I also would like you all to understand is that even though the public healthcare or healthcare in Malaysia is generally highly subsidized, there is still a significant financial burden for patients to come and access the care, not necessarily to pay for the care. And lastly, it is important for you to understand this patient expenditure because it helps you to ensure that you're able to elevate the barriers and ensure a more successful treatment outcome and also a treatment process. So next, and with that, I end. So this is with the message of saying that it's about time for us to look at disease from an economic point of view, especially through the lens of patients. With that, I thank you.
Thank you, Mr. Sivaraj, for a remarkably informative presentation. Based on this presentation, it is evident that taking into account the patient's perspective is also crucial for decision-making. Now, it is time for the Q&A session. Allow me to ask the first questions, and after that, we got the first question. I ask first. Okay, I will direct the question to Dr. Nurzam. According to your presentation, you have mentioned that there is a cycle of poor health and poverty, right? So, in your opinion, what are the strategies that can be implemented to break the cycle, and what is impact on the health?
Okay, breaking the cycle of poverty and poor health is very complicated. It has very complex challenges. So in order to break the cycle, there's a lot of various factors need to be taken into account. For example, if let's say you want to ensure that the cycle is broken, you need to make sure that you have to give access to all to have access to all for quality healthcare. And second, you need to make sure that the literacy of our population also at a certain level. And besides that, you also need to it's also not a single agency or single agency approach. You need to have a multi-agency approach. For example, you need to make sure that there's enough there's a program or intervention by the government that to ensure that the people will be able to sustain their incomes and so on. And also in terms of how to alleviate their poverty levels, and by alleviate the poverty levels and include all those interventions, probably we'll be able to break the poverty and also the poor health cycles. I think it's a multi-pronged approach. We don't have any single approach to tackle or to break the cycles. Okay.
Oh, thank you, Dr. Zam. I think that's a quite comprehensive answer. Okay, I'll let someone from there. Please introduce yourself and then direct your question to the speaker.
Okay, hi, I'm Joanne from IHSR. This question is for Mr. Sivaraj. Hi, Mr. Sivaraj. Thank you for your great presentation on cancer costs. So may I ask, how do these cost information from cancer patients help inform decisions by policymakers to provide more helpful interventions for patients in future?
Okay,
Thanks.
thank you, Joanne. So cost data is actually very helpful. So for example, when we look into the oral cancer, so the government is planning to use teledentistry approach to screen for oral cancer, as most of the oral cancers are detected at later stages. But you see the technology, the investment for the technology is actually quite high. And whether or not we would want to invest, the government want to invest, it depends on how much cost can we be saved when you conduct the interventions. So that is one way where cost data will be able to inform decision makers in terms of preventive care. When we look into treatment then, so for example, you know that cancer treatments are very expensive. Okay, so one of the ways that we can justify investment in very expensive, costly cancer drugs treatments is also using cost data, so that we can actually tell people that, okay, even though the cost of a treatment is very expensive, the preventions or the cost saved from early treatment can compensate for the future expenditures. So addition to that, when we want to do localized policy making, so for example, rather than have a blanket rule, we have policies which are catered to certain marginalized community. We have policies which are based on certain locations, based on urban populations or rural populations, or based on peninsula or Sabah and Sarawak. Cost data helps us to make these decisions. So they are not solely dependent only on cost, but this is one aspect that it can help them to make more informed decisions. Yeah.
I hope that answers the question. Okay, is there any next question? We got another one. Yes, Miss, please introduce yourself and direct the question.
Okay. Firstly, I am Amira Fatiha from IHSR. So my question is, as you mentioned earlier, incentive can driven to one individual behavior. So do incentive effectively influence individuals' behavior towards seeking treatment in the context of Malaysia itself? Thank you.
Thank you for the questions. Looking at in general, there is enough evidence to say that incentive can promote healthy behavior. However, in terms of Malaysia, in context of Malaysia, we have, of course, if you heard about the CCTI just now, Mr. Sivaraj have presented, there is something that there is how to say, the government have done something to use the incentive to improve the completion of treatment of cancer if you look at the CCTI. So, however, the evidence at the moment is not there yet. We don't have any evidence that the incentive for CCTI will improve the completion of treatment for cancer patient. But however, in terms of general, global evidence, there is enough evidence to show that there is actually some effect of incentive to improve the behavior, especially to the better behavior, healthy behavior. Okay. I hope I answered the questions.
Thank you, Dr. Zam. Is there any burning question from the floor? Okay, if there is no more, I might ask one last question. I will direct it to Mr. Sivaraj. Mr. Sivaraj, what are your views on drugs that are deemed cost-effective but come with a high price tag? And why do decision makers hesitate to adopt them?
So this is a good question, especially for cancer. And I'm pretty sure based on the earlier preliminary symposium on the rare disease. So you can see that the treatment for rare disease itself, actually it can be not cost effective because it's too expensive for us to invest in the treatment. But that doesn't mean we don't treat the patient. So like what I said, that cost effectiveness analysis is just one parameter that we take into consideration for decision making. Additionally, there's also certain things such as moral obligations, viable alternatives available, and what happens if patients don't get the treatment. So there is one way. Even if it is not cost effective, doesn't mean that we shouldn't treat the patient. There are still other factors that we'll put into consideration. But for cancer, which is very interesting, a lot of cancer treatments are deemed to be cost effective because that it has a very high effectiveness ratio. But it doesn't mean that at an MOH level at least, we are going to buy all this drug. Okay? Because at the end of the day, it's like a big piece of pie. So if we, even though a treatment is cost effective, in order for us to get that money, we require a huge amount of budget. And this budget would be coming from other diseases. So this is the dilemma for decision makers. So what I will say is that it would be taken into consideration, especially cost effectiveness of drug, but you also need to know whether or not a drug is affordable. It depends on the budget. So for decision makers, they not necessarily use cost effectiveness, they use the concept whether or not the treatment is affordable for its population. So we proceed from cost effectiveness to budget impact and then determine whether or not it's an affordable treatment. And that's how they make decision. It's tough, but someone has to do it.
Okay, thank you, Mr. Sivaraj. I think our symposium has now reached its end, and I trust that our discussion today have provided very valuable insights to all in attendance. With that, I express my gratitude to both our esteemed speakers and the audience. Please give a big applause to our both speakers today. Thank you, and until we meet again, Assalamualaikum and goodbye. Have a great day, everyone.
Thank you, Dr. Nur Amalina and our speakers for a very insightful session. And as a gesture of appreciation, we would like to invite Dr. Muhammad Faruniza Matno to present the mementos to the moderator and speakers. We would like to invite Dr. Nur Zam Azihan Muhammad Hassan. Mr. Sivaraj Raman. And moderator Dr. Nur Amalina binti Zaimi. We ask for our moderator and speaker to remain on stage for a photo session. Thank you, Dr. Farunizal and our experts from IHSR. Distinguished guests, ladies and gentlemen, this concludes the morning session. Before we adjourn for lunch, please be informed that our program will resume at 2 p.m. There will be a parallel oral presentations. The biomedical sciences presentation will be in the auditorium 1, and the clinical and public health system and management will be held in this auditorium Perdana. We would like to invite all participants for a scientific and marketplace poster viewing located at the NIH ballroom and the ground floor concourse, Block D2. We also seek your cooperation to fill up the feedback form for this event by scanning the QR code displayed on the screen. Not yet. Ladies and gentlemen, please join us to